right. Well, good morning and welcome to the seventh Annual AAEM RSA Symposium of the South or Southern region. All right. This event is hosted by our wonderful Ochsner Clinical School, University of Queensland EMIG group, as well as the Ochsner Emergency Medicine Residency Program, also by AAEM and RSA. I am Dr. Ravi Chauhan. I'm the Clerkship Director here for the University of Queensland EMIG sponsor, as well as the medical school. And we're all excited. I mean, everyone that's here is excited to have you here for this event today. We also have a guest speaker who's from AAEM. We'll talk to you a little bit about what AAEM offers and why it's important to be part of the organization to help you not only through medical school, to residency, and as well as beyond. So it's fantastic. We're going to get started here shortly with the guest speaker, but I just want to talk to you a little bit about what we have. Do you have the schedule you can put up real quick? So just to kind of give you housekeeping rules about what's going on today, we're blessed to have some of our core faculty here presenting great topics, everything from toxicology topics to a toxicology escape room. We have in-flight emergency simulation planned. We have an ultrasound competition, then followed by a virtual program director panel from approximately 16 or so Southern medical schools. So that's pretty exciting from the Southern region. So this is an opportunity for you to join your medical student colleagues and sharpen your clinical skills, connect with some of the emergency medicine leaders that are here today, as well as carve out your path to EM, which will be pretty exciting. All right. The faculty involved today is we have Dr. Annie Ahrens, who's one of our core faculty toxicologists, Dr. Daniel Sessions, who's our vice chair of academics. He's also going to be part of the toxicology escape room. Dr. Harriman, she's our core faculty for ultrasound. Dr. Novotny, who's our sim director and core faculty, will be part of the simulation, and of course myself. We'll hear from Dr. Swal, who's our program director, when we get towards the PD panel at the end. So if you have questions, please reach out to him. But let's make sure we thank everyone for taking time out of their busy schedules to be here on a Saturday. So we're excited. All right. We also have giveaway for random raffle, a few gifts as well, and then we have swag for you guys as well. Housekeeping items, bathrooms are right around the corner. For those of you that don't know, just down here. When we go upstairs to the simulation rooms for simulations, try not to take any food directly into the simulation rooms, but you can have everything down here. All right. And then your EMIG reps are here as well to help facilitate. All right. I'm going to introduce our guest speaker. And hopefully I can say her name right. Let's see if I have it. Was it Wazinski? Am I saying it right? All right. Dr. Katie Wazinski. Did I say that correct?
Good, great.
All right, great. All right. So she serves as the president of the American Academy of the Emergency Medicine Resident and Student Association, or AAEM RSA. She earned her Doctor of Osteopathic Medicine at TCOM in Fort Worth, Texas, actually my alma mater. It's where I went to medical school, so very exciting. She did that in 2024, and she also holds a Master of Science in Biomedical Sciences from Duke University. We won't hold that against her. But Dr. Wazinski's professional interests include medical education, mentorship, point of care ultrasound. She's deeply committed to advancing the next generation of emergency medicine physicians. She also has an interest in street medicine and health humanities. She wants to promote equitable care for underserved populations. So we're really excited to have her. She's going to talk to you a little about AAEM and what they offer. All right. Dr. Wazinski, you're free to go.
Can y'all hear me okay? I assume someone would yell if I, if you can.
Yes, we can hear you.
Perfect. And it looks like there are also some people on the Zoom. So this is really exciting. I know that we have been doing these symposiums for many years now, and we have managed to do it through COVID. And now we're doing somewhat of a hybrid setup. So thank you all so much for being here. I'm so sorry that I couldn't be there in person. I'm in the midst of our medical ICU month, and I just got off off of a night call. So I apologize if my words are garbled. Hopefully I'm not gonna stroke out and it's just lack of sleep, okay? But yeah, thank you all so much for being here, whether you are virtual or in person. These events are really such a unique opportunity for medical students, and the networking, especially if you're in person with other medical students, residents, and faculty that are at the event and taking the time to be there and educate and be a part of it. And thank you so much to the co-sponsors who are hosting this amazing event. It is really awesome to see. So thank you so much. That introduction was so lovely. I am the current AAEM RSA president, and I am just going to give you a brief overview. Hopefully you all are members of our organization, and if not, I'm just going to give you a quick spiel about what we are about and why you should join, and some awesome benefits that we have, including this event and many, many others that you can be a part of. So talking about any really national organization, but especially AAEM, it's interesting to look at the context of emergency medicine and who we are as a specialty, especially if you are potentially a second or third year medical student looking to join the specialty. Thinking about who we are historically and where we are going as a specialty is really important. So really, we started as a unique specialty in the 70s, which in the House of Medicine is very young relative to other specialties like family medicine, internal medicine, etc. Before that, you had colleagues who were trained in various other specialties who were working in emergency departments. And so emergency medicine as a residency really did not start until the 70s. People started to realize that in order to be a good physician to really treat emergencies, that you had to be trained in this field and have a specific skill set. And really, it was not formally recognized as a specialty until 1979. Then subsequently in the 80s and 90s, there was a lot of controversy because people still wanted to work in the emergency department and were grandfathered into the specialty as people were becoming to be resident trained. So the first ABEM board exam, which in case you don't know, for any specialty, you have to be board certified specifically in that specialty. So the first American Board of Emergency Medicine specific board exam was in 1980. To actually certify and credential for emergency medicine board physicians. And that is something that AAEM holds near and dear to our heart, is that we really recognize the importance to being board certified specifically in emergency medicine. So that was the very first board exam. And then in the late 90s and 2000s, kind of more controversy around the field, specifically in unfair business practices. So many leaders in many different states in emergency medicine were doing things such as hiring less qualified people, potentially who were not emergency medicine trained, to staff their EDs, usually at a cheaper rate to maximize profits. I'm sure you have all heard of the corporate practice of medicine. And so this started really in the 90s and 2000s, and the emergency department was really ripe for profit, especially in this time. So corporate practice groups took over many emergency departments, and subsequent lawsuits started happening in that time frame. And this is kind of the context of which AAEM started to be an organization in this context of illegal practice of medicine. So we were founded in 1993, which again, we are a pretty new organization in the field of organized medicine, really focusing on anti-unfair business practice of medicine, corporate practice of medicine, et cetera, et cetera. So subsequently established in 1993, really to promote fair and equitable practice environments for specifically board certified emergency physicians. And Dr. Keeney, who wrote this book, was really at the forefront to deliver high quality care in equitable business practices. So fast forward, AAM RSA, which is a separate organization entity. So if you think about, I'm sure you all have heard of EMRA and ASEP, kind of similar in terms of structures. They are both separate organizations. AAM RSA started as a section and then became our own entity in 2005. So we really are the organization for both residents and students, for both national and international medical students and residents. So I'm not going to belabor our vision and mission statements, but we really do believe that we are the advocacy association for trainees, both advocating for our practice environments, but also for our medical students and our residents, so that they can become the best board certified emergency physicians that they can be, and really leaders in the field. And here are just a handful of our values. I think it is really important. We say these at the beginning of every business meeting that our board hosts, really to put the forefront of our organization, focused on these mission, vision, and values. And again, mission statement, advocating and educating both medical students and residents, very important to us. So now to the nitty gritty, what we offer to you as benefits. I will say, especially if you're early on in your medical school time, MS1, 2, even 3s, it is really beneficial to join a national organization. And there are many national organizations in the emergency medicine landscape. ASEP, SAEM, AEM. There are so many acronyms to choose from, and they are not mutually exclusive. I know that it can be expensive to join these organizations, but AEM RSA specifically has very competitive pricing and benefits, so you can really get the most bang for your buck. So here are just the start of some of our benefits that we offer. So for instance, on that left-hand side, if you have heard of MRAP, it is one of the leading medical knowledge for emergency medicine specifically. And so we offer that to you for free. If you were to just buy MRAP itself, it is very expensive as a resident or a medical student, along with a whole host of things that we offer online, and then a lot of discounts to very important other educational offerings. Really interesting. We have both ITE exam review, and then as the board exam is actually changing the oral boards, we are creating a brand new oral prep course. And so that is part of our benefits that is very important to residents, especially in the next few years, who are going to be taking boards. So if any of you know residents, or if anyone is in a residency program, or about to be interns, definitely something to think about. Podcasts, journals, magazines. We have so many different publications, not only for you to digest, but also I would encourage you, as a medical student, to really take ownership and leadership to, if you are interested in publishing a piece, whether that is in more of an academic journal setting, or even in our magazine or online publication. It doesn't matter if you are an M1 or a resident or a faculty member. We welcome any sort of writing and publication, and we can work with you to edit. We have a whole publications group actually, that meets every so often and can guide you through the process of what that looks like. And then lots of different podcast offerings. Another thing which I think is really cool and unique is that we continue to publish actually physical booklets. And so the EM Bedside Ultrasound Guide, if you do become a member, you get it in your membership box. And it's really great for both the medical student and like a brand new intern level, of the basics in ultrasounds. We are in the process of developing an advanced ultrasound guidebook as well, with some blocks and kind of the next steps for PGY2s and 3s. If you are doing rotations this fall, or if you are an 3 going to apply next year. This gut sheet, if any of you have done your internal medicine rotation and bought those little booklets from Amazon that have the HPI and everything listed out that you can interview patients, these are very similar, but more in an emergency medicine standpoint and framework that will help you crush your sub-internships and also your presentations to your attendings and residents. So it's great even for interns, I would say, as you're starting to figure out how you take notes and how you present. And then the critical care pocket guide is actually one of my favorites. I use it very often. It is literally fits in your pocket, and it has the most high yield things that you need to know, from ventilator management to how to interpret an ABG and what to do, what are the next steps, very common presentations and resuscitation of those presentations. So even if you are a medical student rotating in the ICU, or you see a lot of critical patients in the emergency department, this booklet is so helpful. And I would really recommend you look into it. CME, again, we have a lot of CME. It's not as important for medical students, but just to be aware, we have all of our past scientific assemblies. We have extra CME online, more important for young physicians who have CME requirements. And then events, we have so many events throughout the year, and then ultimately culminating in the spring with our scientific assembly. But we have a lot of symposiums. You are here, so you know about this. But even if you are interested in going to residency in another region, we have virtual offerings for all of those as well. And then this event is actually happening next week. I will be hosting it with some of our California AAEM people, talking about strategies for how to navigate student loans and debt, especially in residency and being a young physician. So we have some really big names and people who are very well versed in this field and topics, and it should be a really interesting conversation. It will be recorded, so if you cannot stay tuned in this time frame, don't worry too much, but highly recommend you look into that. The Introduction to Critical Care is an annual course that usually starts in January and then culminates at our scientific assembly. And this kind of expands on that little pocket guide. But week to week, you go over very common critical care presentations, procedures, etc., really diving deep into all of these topics. I was a participant. I had so much knowledge from it. I wish that I had this before I rotated in the ICU as a medical student. It's so helpful, and you get a certificate of completion, and then there's a specific course at scientific assembly. So you do have to pay to be a part of this course, but the knowledge that you gain from this is invaluable, honestly. And then scientific assembly. So next year, April 11th through 15th, the medical student portion is the very early part of scientific assembly. So it's usually like the 10th and 11th. And that is kind of similar to these symposiums, but on a much larger scale. And the great thing about our scientific assembly is that even as a medical student, you can be a part of really anything that the scientific assembly has to offer, whether that is a committee meeting, whether that is a small group discussion, or learning a new procedure or something like that. And it is essentially free for medical students. So there are specific resident and student tracks, including hands-on sessions, but then, like I said, you can go to any of the sessions that are being offered in the entire conference. And then we have a separate health policy and emergency medicine symposium that is held in DC, usually in June. And we all go to the Capitol. We have some lectures to kind of prep you. And then we go talk to our congressmen, women, senators, and we advocate for important policies that are facing emergency physicians and specific policies that AAEM is focused on. And it is such a unique experience. Would really recommend, especially if you're interested in any sort of policy, legislative agenda items, and the future of emergency medicine at large. Other opportunities, you can apply for a board of director position on the RSA board. And then we also have a medical student council board. Those positions actually will be opening up here late November, early December. So definitely I would recommend becoming an RSA member and certainly apply for a position. You can apply to be your regional representative if you are in a medical school in the South or potentially even internationally. Or the chair or vice chair. Definitely that is how I got my start, as I was on the MSc and continue to be involved in residency. And it's such a great opportunity, not only for networking and building your own leadership, but it looks awesome on your CV, and for residencies to see that you are involved on the national level is really an incredible opportunity. And then the Cabinet of Delegates is a group of individuals that has one representative from each school and residency. So if you are unsure if your school has a Cabinet of Delegate member that is represented, you can reach out to me and we can figure it out. And if not, then you are more than welcome to be that person. Lots of different sections and work groups that you can be a part of. Like I mentioned before, we have publications, we have wellness. We recently did a restructuring kind of the logistics and back end of what the organization looks like on RSA and on the AAEM level. But like I said, as a medical student, you can be involved in really any group that both RSA and AAEM has to offer. Women in Emergency Medicine, it's both medical students, residents, and attendings, young physicians, etc. And I have been a part of that group for many years now and made some really amazing connections and lifelong friends. So the world is your oyster. Whatever you want to be involved with, you certainly can be. And then if you are interested in being a medical student ambassador, specifically for Scientific Assembly, you do get a little bit of reimbursement for your travel and hotel, etc., for coming to the Scientific Assembly and helping out with various tasks. It is very helpful for mentorship. You actually get a mentor that might be on the board, that might be a program director, etc., and you get really one-on-one mentorship and networking that is that's an awesome opportunity. And then here are our social media. And I think that is all I have. I'm happy to take any questions if you have any. But I know you are all probably excited to engage with the events of the day. So again, I just want to thank you all for being here and have a really wonderful day. Take advantage of all of the opportunities, whether you are virtual or in person. It's awesome that you are here and involved, and I hope to see you potentially in Seattle for our in-person conference.
Thank you, Dr. Rosinski. That was wonderful, wonderful information for the students. If anybody needs to take a quick restroom break, we'll get started here in about 5 minutes, okay?
Yeah, they know. So,
What's up, y'all? Good morning. Don't be all the way over there. Come over here. Come over here. Come over here. We're not doing that.
Everybody gather
Come over here. It's not that.
Bring my daughter.
Sorry, everybody in Zoom land, for rearranging. While we're moving around, for those of you, ooh, that's fun. For those of you who don't know me, I'm Annie Arns. I'm one of the medical toxicologists here at Ochsner. So my journey, I grew up in Minnesota, went to undergrad, I was a Badger, so I went to Wisconsin. Came back to University of Minnesota, the Twin Cities campus, there's 2 campuses, for medical school, residency at Denver Health, which is 4 years. Went out to San Francisco, worked for a year, did a 2-year tox fellowship at UCSF, and then came back to Hennepin. I was at Hennepin County for 6 years before we moved down here about 3.5-ish years ago. My husband, who you'll meet soon if you haven't met him before, Dr. Sessions, is one of our other toxicologists who grew up outside of Baton Rouge. So that's how we got down here. So both of us are board certified in emergency medicine, toxicology, as well as addiction medicine. So up until literally this year, unfortunately, sorry guys, there was a pathway to do addiction medicine certification, so board certification without doing a fellowship. So that pathway was open for emergency medicine, occupational medicine, internal medicine, and a few other specialties, and including toxicology up until this year. So that's how we got board certified in addiction medicine. So that's what we do now. So we're in the emergency department here, obviously just at main campus at Ochsner. And then we do medical toxicology call and answer addiction questions, primarily for buprenorphine, methadone, opioid use disorder, and then some other complicated withdrawals like alcohol withdrawal, et cetera. We take those calls for the entire system of Ochsner. So we only see bedside toxicology patients here at main campus. So if you have questions about any of those things, let me know. So our fellowship is one of the only 2-year fellowships outside of critical care for emergency medicine, and you can go into that from like a billion different specialties. So that's my story. So if you have questions about any of that, let me know. We're gonna talk about mushrooms, and so we'll move along. We'll move it right along. All these mushrooms, just BT dubs, are going to focus on North America. I don't know much about Australian mushrooms, so we're going to focus on ones that are here in North America, not necessarily Louisiana. So obviously I have no disclosures. We can move on. So mushroom poisonings, and we'll move on. One of the important parts about mushrooms is how to identify it. Mushrooms, as you may or may not know, are like the sexy bits. So it's the fruiting body of the mushroom itself. So the fungus grows usually on the ground, underground is where you find them. And then as it tries to release spores, that's when you see the actual mushrooms above ground. There are a bajillion different species. There's 5,000 plus species that are in the United States. Not all are native to the United States, but those are the ones we identify here. And only about less than 2% of them are actually poisonous. But most of our poisonings that we see are in patients, obviously in pediatric patients, so less than 6 years old, which is pretty consistent with our overdoses overall, or exploratory ingestions, and usually it's raw mushrooms. So it's usually like a kid who's out playing with something, they decide to eat mushrooms, which is like, what have I taught you, child? My kids, I freak out when they get next to mushrooms. So, but it happens all the time. Our next slide. So identifying mushrooms. Is anybody here like a mushroom forager? Yeah. How's it going? He's like, I'm still here. Cool. What do you use to forage? Do you use a book? Do you use?
I use a book and then a lot of YouTube and TikTok.
A lot of YouTubing. I love it. So let's talk about some of the parts of mushroom anatomy. So when we talk about mushrooms, how to identify them, for example, or if you call and you tell us like, hey, we have a kid who ate a mushroom, you're like, rad. And that's the end of the sentence. Like, we need more information. So these are some things that we'll talk about. And these are just different anatomic pieces of a mushroom itself. So the top part, of course, is the cap, just a little cap. And what part of a cap do you think would be important? What information would be important for us to know as toxicologists?
Pattern.
Patterns on there, yep. Colors are important, exactly. Size can be really helpful. And these are all relative, right? Because there's such things as baby mushrooms that grow to be this big and they start off this little tiny, that we'll see pictures. But size, color are really helpful. If it's flat, if it's round, if it's a cone shape can be helpful. And then the gills are what we call those little gilly things underneath. We also want to know if they're attached or not. And what would be, besides that, important about gills that we'd want to know? Number? No, that would be hilarious. We're like, count them. 2,000. Color. Yep. So color. So what is the underside? You know, like the porcini mushrooms you buy, whatever. What color are those gills?
Black.
Black. Or portobello mushrooms. What are those?
Dark brown.
Dark brown or black, right? Should be. When we talk about the poisonous mushrooms that we really worry about, those are cream or white colored gills. So those are really important if there's bruising or something like that. The stalk there, that's like the tree trunk, we don't ask too many questions about, but an important thing you'll find on there is the ring or an annulus on there. And that's, we'll talk about what a universal veil is, but that's a remnant of a universal veil. So as that little baby mushroom grows up, it has like a covering over it, like a veil, and then it like pulls away and it can leave a ring. So some of those, especially Amanita phalloides, we care if there's a ring or not. Once mushrooms have been handled, a lot of this just like goes out the window because they'll bring in like pieces of a mushroom and you're like, what was the stalk? They're like, what's the stalk? And you're like, okay, never mind. JK lulz. The very bottom, so imagine right here is where the dirt is. So the cup that you see there, also known as a vulva, is sitting usually in the underground or in the ground. So you might not always see it because usually once you pick a mushroom or like kick it over, boop, that cup stays in the ground. So we don't always see those, but those can help you identify them too. Mycelial threads, there's like an amazing, I think it's Radiolab about mycelium, which we're not going to talk about, which you can't see, but they like, this is how they connect to each other and like they do magic. Mushrooms are magic for many reasons, but mushrooms are magic and they talk to each other. It's cool. But they speak to each other through mycelium. So we'll go to the next slide. I just got my nails done. So it's very ASMR. So this is an example of baby mushroom on the far left side that grows all the way up to an adult mushroom. They're not actually called that. I just call them that. But this is the universal veil that you see. So you can see how all these little mushrooms, these button mushrooms, will look exactly like the kind of mushrooms you would just buy in the grocery store. So just because it's not a flat brown top and it's covered in that universal veil doesn't always mean it's not that poisonous mushroom, if that makes sense. So baby mushrooms can be difficult to identify because they all look the same. But you can see what that one that's pointing at there, you can see that there's that universal veil. So it looks like one big blob of mushroom, essentially. And as that pulls away, you can see how it leaves behind sometimes some speckles on a cap and then that annulus on that stalk is important. Next. If you look, this is from Wikipedia. So all these characteristics, I like Wikipedia for this, and I'm saying on record that I like Wikipedia, so don't judge me. But when you look up the mushrooms, it'll give you each of those sort of parts. Some other ways we can identify mushrooms, and we'll go to the next slide. Obviously, you can use books. Keep going. The interwebs, there are some like Facebook sites that you can post pictures of, and then people from the community will tell you what it is. This is sus at the very best. They'll be like, I'm a mycologist, and you're like, Google it. And they'll answer it. But they do have these, especially if you're like walking around. If you have somebody who ate something, don't use these. But if you're like out in the woods and you're like, what is this? Don't eat it, but you can identify it. Next. The location is really important. So some mushrooms have what's called a mycorrhizal relationship with certain kinds of trees. So for example, most Amanita phalloides you'll find near pine type trees or evergreen type trees. And so where you find them is really important sometimes in identifying a mushroom. That becomes completely out the window when you have manicured type lawns. So if you think about how mushrooms and fungus work, they don't care where they are, right? So if you have a bunch of mulch that has spores from another mushroom, you take that from wherever that came from and then dump it around whichever tree it's around, those mushrooms can grow and sprout. So if you have like a manicured lawn and not an evergreen in sight, it doesn't mean that those mushrooms can't pop up because that's how, remember, life always finds a way. Next. The size, the color, and the shape, like we talked about, can be really helpful. Some are really easy to identify. Like this is Amanita muscaria that you'd be like walking, typically in Europe. We don't have them here for the most part. You'd be walking in Europe and you'd be like, I know what you are. Don't eat it. But you can identify some of them. But again, they all look the same. And then the next slide is a spore print. Has anyone done a spore print? You gotta be real bored to do a spore print. But everybody do this. Find a mushroom in your backyard. If you don't have children, don't bring it in. Essentially what a spore print is, remember that these are the fruiting body of the fungus. So this is designed to make a cap and then spores kind of rain down from the cap, and that's how they spread. If you take the cap and you put it on, usually we'll do it on a piece of white paper and then a piece of darkly colored paper, blue, black, something like that. It'll drop spores, so you leave it there for about 24, 36 hours, pick it up, and you'll see a print and pattern from the spores that have been left behind. And it's usually a color and a particular pattern that helps you identify the mushroom. If you have taken the time to do a spore print to identify a mushroom someone ate, they are fine. And you have too much free time. If you're like waiting to treat them until you get a spore print, like either you're doing something wrong or they're totally fine. But it's a fun project. And then you can, next slide, you can also, if you're a mycologist, you can look at the spores themselves. And their spores, typically they'll do a combination of their anatomy and what they look like, and then spores to positively identify a mushroom. This is called a Ochsner test. Has anyone heard of this? So this was designed, this is not a great test, but this is to identify and we'll talk about them, the cyclopeptides in the Amanita phalloides. So essentially you like take a little bit of the mushroom, grind it up, and it has to be on actual newspaper, which like none of us have anymore. It can't just be regular paper, it has to be newspaper. And you take a little bit of potassium, potassium hydroxide, and you put a dot on there. So this is what it normally looks like. Sorry, everybody who's at home. And then this is what a positive test looks like. So if you're at home, this blue color that you see, in theory, should identify positively a cyclopeptide. That's from like an Amanita phalloides or something like that. This is very unreliable, but super fun. Not that you have potassium hydroxide sitting around, hopefully. Because I don't know what you're doing with yourself. All right. We're going to go through some mushrooms. We're going to talk about 5 important, when we talk about mushrooms, we typically break them up into not genus and species, but what their toxin is. So that's how when we think about these, that's how we kind of break them up. This is the most important quote for mushroom foraging. People forage mushrooms. And again, the last quote of the entire thing is everything is edible once. Every single mushroom, everything is edible once. So there are old mushroom hunters and there are bold mushroom hunters, and there are no old, bold mushroom hunters. So don't eat mushrooms that you find. Next. Okay, so the first one we're going to talk about cyclopeptides, and we're going to spend the most time on these because this is what kills 90% of mushroom eaters who die. So not all mushroom eaters, but people who get sick, 90% of them are this category of mushroom. Does anyone know what this mushroom is? I wouldn't either if I didn't do a whole fellowship in it. Go to the next slide. So these are varieties of the Amanita species. Will you go back to the previous slide real quick? So this is probably the most important point for y'all when you're worried about mushrooms. So we worry about things that have white or cream gills, here at least in North America. So if somebody has something with a brown gills, something like that, you might have other problems, typically just nausea, vomiting. Most mushrooms just make you puke and have diarrhea if you don't buy them from the grocery store. But you can see, how would you identify this one based upon the things that we talked about? Flat top. We describe them as like pancakes almost. So they're usually about this big once they like are fully grown. They're gigantic. And they're like white or cream color on the top. And then what about the gills?
White gills.
Yeah.
I don't know.
It's a little tough to tell. I think they're unattached. I can't remember. They're there, but they're white and cream colored. What else on these do you see?
The veil residue. Vanillus.
This guy, remember this one? I wanted to make, as an aside, I really, as a fellow, wanted to make a mushroom calendar called Vulva of the Month. But that's an aside. So I'm pointing these out because these are the most important mushrooms to identify. So go to the next slide, my friend. So the most common ones that we see are the Amanita phalloides on the left-hand side. So again, burn in your brain, white or cream-colored gills are the most important thing to identify them. And then Amanita verosa. So these are called death caps, and these are called destroying angels. You're like, I'm going to eat this destroying angel and find out what's happened. Like, okay, F around and find out, girl. Go next. There's some other species that contain similar cyclopeptides that are not as toxic. So the Galerina and the Lepiota species. You can go to the next one. The Amanita species, again, oh, I'm sorry, death angel or destroying angel. So again, important things that we already talked about are the size and the color. And these have mycorrhizal relationships with trees. So you'll almost always find them next to a tree, typically pine or evergreens. And again, responsible for about 90 to 95% of the mushroom-related fatalities. And the fatality rate, depending on how much you eat, and it's all dose dependent, is upwards of 50% case fatality. So pretty significant fatality associated with them. One full mushroom is enough to kill not just one adult, but multiple adults. There was a recent case, was it in Australia? Yes. Where that girl, like that lady poisoned her whole family? Very common story where like there'll be like 4 or 5 people who ate a mushroom stew and like one person is fine. And they eat usually just enough to get a little bit sick but not die. It's a very, very sus, very common situation. And they're like, think they're gonna get away with it. And we're like, okay. Next. The primary toxin that's responsible for this is called alpha-amanitin. It's exceptionally difficult to test for, very difficult to identify. There's one lab that I'm aware of in California that can reliably identify it, and typically we have to identify it in bile. The half-life of this is 6 hours or less in the periphery. So by the time somebody's already sick, it's usually gone. Kind of makes it a perfect murder weapon. It is pretty poorly absorbed, but it undergoes enterohepatic recirculation. So as it's released in the bile, it gets retaken up through that enterohepatic system, and so you continue reabsorbing it. It gets taken up by the oat families on the hepatocytes, and it interferes with RNA polymerase II. So what would be your clinical effects that you'd expect? We're going to talk about it, but what would you expect? So if you were to interrupt proteins, you can't answer because we talked about it. If you were to interrupt protein synthesis, what would happen? What kind of drugs do we use that do that? That interrupt? Chemotherapeutics, yep. So what happens when you get chemo?
Kill a bunch of cells.
Kill a bunch of cells. What usually goes first?
Like GI
Those
stuff.
Yep, things that, yep, so GI side effects. So what would you expect for this one? Nausea, vomiting, diarrhea, early or delayed?
Delayed.
Delayed, why?
Because it takes time for the products to break down and actually enter the hepatic system.
Exactly. So the biggest thing is you already have proteins that have been created, right? So you have to outstrip that supply of protein. The problem is creating new proteins. So you still have some time, and then it's basically a human antibiotic, a lot like ricin. So if you look at on pathology, you'll see central lobular hepatic necrosis with typically intact structure if you were to do a liver biopsy. So if you see, again, you have somebody who comes onto your internal medicine service, they have nausea, vomiting, diarrhea that you can't explain. Their wife is like skipped out to Cancun, and you get this, you can expect that that was from this mushroom. Next. This is what it looks like, which is why it's called a octapeptide. So it's got 8 cyclical structures in here. Go next. This is not important. It's just big. This is why it's difficult to identify. And this is what you see. So you see that sort of paracentral hemorrhagic necrosis, but overall the architecture is still intact of those liver, those hepatocytes. Go ahead. So this is one of those ones, for some reason, like in the 60s and 70s, we were super into naming stuff in phases, like iron has one of these. So this is one that has a phase. So just like we were saying, so typically they'll be pretty asymptomatic for about 5 or 6 hours. After that, they'll have really profound nausea, vomiting, diarrhea. So this is like cholera level diarrhea. We don't see cholera in our country pretty much ever, but it's like just continuous watery, loose bowels, not typically bloody, but typically just significant diarrhea. What would kill people in this first phase? Dehydration. So we had a patient who was in a locked psychiatric facility that had a manicured lawn, that had these mushrooms growing outside, that he ate one and then concealed it and concealed his nausea, vomiting, and diarrhea for about 13 hours or so. When he got to the emergency department, his creatinine was through the roof. He was severely dehydrated. He was hypotensive, and that was all from GI loss. Typically, you know, like there's this quiescent phase. So what's happening during that quiescent phase?
But it's metabolizing. trying to develop the toxins.
Yep. So what would you expect to be doing with your, I'm going to say LFTs, even though I know they're not liver function tests. And I know transaminitis is, yeah, typically. So if you had somebody that ate a white or cream colored gilled mushroom 2 hours ago, totally asymptomatic when they came into the ED, what would you do?
Like,
Would you send them home?
No, because I know they're gonna get sick.
Yep. So what would you do?
Are there antitoxins?
You could train their LFTs. So we typically just watch them and for about 6 hours, 8 hours, make sure, we'll talk about charcoal. So we typically treat them with charcoal. We usually watch them to make sure they don't develop nausea and vomiting. If they're at home, we usually recommend they come in. If you're on the phone with poison control, we recommend they come in so we can give them charcoal. But if mom and dad refuse, then at least bring them in if they start vomiting at 8 hours. And then plus minus check LFTs, and then we'll kind of watch LFTs during this phase. So ultimately what happens, and they end up with just multi-organ system failure, usually starts with liver failure, and we'll need to go on to, a handful of them will go on to transplant. The people that are typically die are people that are late to presentation or extremes of age, so young or old are the people that typically die from these. Go into the next. Therapies, you'll read a lot. Once you start digging into these, you'll see a lot of different things. So you'll see theocytic acid is one. You'll see cimetidine is another one, with the idea being that you're reducing your bile release, as in you're like inhibiting gallbladder squeeze. There's not great data for anything. So the therapies that we typically do are multi-dose activated charcoal, that's MDAC at the bottom. So we'll give you a dose of charcoal now before you start puking. Try and get a second dose in them in the next 4 to 6 hours. Typically they have so much vomiting they can't keep anything down if they are truly sick. N-acetylcysteine is like our favorite thing in the world. So like anything that's liver, we're like, yeah, give them NAC. There's a little bit of data out of Europe for N-acetylcysteine, so we tend to just start them on the typical Tylenol protocol and continue it. There's not great data for it, to be very clear. High-dose penicillin is something you'll read a lot about. Does anyone know why we talk about high-dose penicillin? Or do you remember why?
same RNA mechanism.
So the high-dose penicillin, it will block the uptake of the alpha-amytin at the OAT transporter cells at the hepatocytes. Not great data that this actually works, but you'll still see GI, for example, will often give them high-dose penicillin. It doesn't hurt my feelings. It just doesn't work. And there's so many allergies to penicillins, well, allergies to penicillins, that often we can't give this. It doesn't work great, but it doesn't hurt my feelings if they want to do it. And these are like millions of units IV. Silibinin, has everyone heard of silibinin or milk thistle? Yep. So milk thistle, silibinin is essentially an IV form that's derived from milk thistle. Silibinin, again, it has some data that comes out of Europe that shows some mortality benefit to it. It's not available in the United States, so you have to have an IND for it, and you have to get it directly from the producer in Germany called Legalon. It's difficult to get and has to typically be started within the first 6 hours. So if we know somebody had an ingestion or we're super concerned about it, we'll try and get it. It takes a lot of time, but it's not really readily available in the US. So our typical treatments will be MDAC and N-acetylcysteine is what we do for the most part. And then fingers crossed. Next. I moved on too quickly, but the end stage of this is they either recover or they need a liver, and it's all dose dependent as far as we know. So we do all these therapies, but it's largely dose dependent on how much they ate. So what color mushrooms do you care about?
White and green gills.
That's the one. So if you hear that, doesn't matter where you are, anywhere in North America, you care about white and cream colored gills. Those you send into the emergency department, no matter what. You call us or you call poison control. Those you care about. We have not had any Amanita phalloides in Louisiana for the last 3 years that I'm aware of, at least at Ochsner. I don't know about poison control. So this is primarily Pacific Northwest. But white and cream colored gills, just say no.
So
drugs.
when people die, it's because of like the early stage, like the dehydration, and then you get help, or like the liver failure, and that happens, right? Like,
depends on when they present.
Yeah.
Most often we can get them through the dehydration phase with just supportive care. And then it's multi-organ system failure, primarily liver failure,
okay.
that we just have to hopefully support them through. So we have no antidote for it. So by then you're just not making proteins, and you just have to hope they live long enough that they can start reproducing all that RNA polymerase.
But like
Pretty nasty.
timeline, it's like a couple of weeks, like if they work on it.
Depends.
Sure
Depends.
thing. Okay.
Depends. We have people who died within days, and then people who've lived for weeks and then die of overwhelming sepsis, renal failure, hepatic failure, or something like that. Pretty nasty.
How early do you have to get them to charcoal?
As early as you can. It's the best answer I have. Super exciting. Where it's like, is it gonna work? I don't know. Did it get better? I don't know. Does it help at all? I don't know. Do we do it? Yeah. Why? I don't know. It's most of the talks. It's not great.
What would make someone qualify for a liver?
Pretty much anything. So these people, especially young, healthy people, would scream up to the top of the transplant list. So like if I, as a young, healthy, like Daniel's like, this, I'm sick of this lady, and decided to poison me tomorrow as a relatively young, healthy person, I should scream up to the top of the transplant list, which is true for most overdoses, Tylenol, et cetera, because they usually do well. Especially if there's no underlying psychiatric issues that they have to wade through, you should scream up to the top of the list. And we don't have any, there's no shortage of livers in New Orleans.
Do they have to reach like a certain level of sick? Obviously, because if they pass
Yep.
through, then
It would just be the typical transplant criteria for all comers for liver failure. So there's nothing special. We don't have any special grading like we do for Tylenol, the King's College criteria for when we would think about transplant. So for these people, when they start getting sick, if they're not at a transplant center, we recommend transfer to a liver transplant center, for example, for evaluation. Because with any luck, they should scream up to the top because they get sick pretty quickly. Other questions? Comments or concerns? Okay, all right, next. Gyrometra containing mushrooms. Does anyone recognize these? Brains, right, good. That's a perfect thing to remember for these. Which ones? Go to the next slide for me. Boop. So, are you guys familiar with morels?
Yeah.
Yeah, so I should have taken them away. So morels here, gyrometra here. Are they easy to tell apart? In this picture, they kind of are, but if you were like in the woods, would they be easy to tell apart? Not really. This is why you don't go foraging mushrooms. So, does anyone know anything about gyrometra species and what the toxicity is? Nope. Perfect. Hit next. Next. So, oh, before I forget, the phallotoxin, the amatoxins are also heat stable. So you can cook the mushrooms and it doesn't matter. So how much does that suck? So gyrometrin is the primary toxin that we think about for these gyrometrin containing mushrooms, shockingly. And these are heat sensitive. So if you cook these mushrooms, you actually get rid of the toxin. However, the vapors might actually be toxic, which is, I know. The world is designed to kill you, to be clear. So the gyrometrin is metabolized, this monomethyl hydrazine. The word hydrazine, spark, not, and Charlie can't answer. Does hydrazine like spark anything in anybody's brain? What is hydrazine? It's rocket fuel. What would happen if you, I know, obviously. What would happen if you drank a bunch of rocket fuel, hydrazine?
Nothing good.
Nothing good, that's a good answer. You don't become like a superhero, that'd be cool. It's like Spider-Man. Hydrazine man.
I mean, he'd probably die.
Maybe. You can be like, great. So let's go to the next slide. We'll talk about the toxicity in just a minute. So typically, and we'll talk about how this happens, again, you're usually asymptomatic for about 6 hours or so, and then you start puking your guts out, and I don't know what that toxin is. There's some other emetic toxin that just causes nausea, vomiting, diarrhea, and then you start to get seizures. You can get like, typically they just get like a little delirious and a little bit of nystagmus. They almost look just intoxicated, but can also cause seizures. I put this picture up there in case for some reason you have to go mushroom foraging. Between the morels and the gyrometra, they look very similar. The one thing that you can tell is that the morel, when you cut it open, is hollow inside. The gyrometra are not. So if for some reason you must go find morels and you hope they aren't gyrometra, cut them open. The ones you can eat should be hollow inside. Go to the next one. Next slide. Boom. Okay. So everybody remembers, I know you all remember this. Everybody remembers that GABA, I love this about the human body. GABA is derived from glutamic acid. And glutamic acid or glutamate is one of our main excitatory neurotransmitters, right? GABA is being our primary sedating neurotransmitter, right? So in order to make GABA from glutamic acid, you have to have GAD, and that uses pyridoxal 5-phosphate as a substrate, right? Next slide. Hit me. That pyridoxal 5-phosphate requires PPK and pyridoxine, vitamin B6. Is this starting to sound familiar to anyone? What other medication has a similar profile? What am I getting at? It's a TB medication. Ah, what happens with an INH overdose? Seizures. And how do you treat it? B6, right. Okay, hit the next one. So very similar to INH and hydrazines, these all have a very similar mechanism of action, where they prevent essentially the conversion of glutamic acid to GABA. The other thing that these mushrooms do is they actually they inhibit pyridoxal 5-phosphate, and they also increase the clearance of some of these. So essentially you seize, like it's going out of style. Pick the next one. Just gonna leave it up here to make everyone nauseated. So if you had a giant meat mushroom that came into the emergency department, how would you treat it? They're seizing. First thing, benzo's great, and you would check a glucose.
B6.
B6, pyridoxine, and how much?
A lot.
A lot. What's a lot? How do you treat an INH? Does anyone know? It's like 5 grams of pyridoxine. If you've never, the vials of pyridoxine come in 100 milligrams. So if you've never treated this, you'll have, the nurse will come up with like a pile of them, and you're like, this doesn't seem right. And which is the right answer, right? Whenever you're opening multiple vials of something to give to someone, you should be like, this doesn't feel right. So they'll end up with like a pile of pyridoxine, and they'll be like popping them open. It's just like boop, 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 boop. Like they're like making it rain pyridoxine. And so they'll have vials and vials, but we start typically with 5 grams. And this is an adult dosing. There's mg per kg dosing for pediatric patients, but typically it's like 5 grams of pyridoxine, which is a lot. Is that gonna hurt them? No, it's just a lot of B6. Next. Okay. We don't really know if early GI decontamination helps or not. We typically give them, if we know somebody ate one of these for some reason, we'll give them just regular activated charcoal, not typically multi-dose. And then benzos are always the right answer for seizures, and then vitamin B6. Cool? Yeah. Next. All right, muscarine containing mushrooms. We're gonna scream through the next ones. Does anyone recognize these? I don't. These are actually European. Sorry, guys. I said North America. They kind of look like upside down umbrellas.
Oh.
A little bit, or trumpets.
Yeah.
Cool. Next. So these are the Clatosape, that's pronounced Clatosape and Inosabe species. They're really pretty. We don't have them much here in the United States, typically in Europe. Go next. There's some other ones. So on the left-hand side, they call this the sweater. I'm not 100% sure why. Jack-o'-lanterns on the right-hand side. Go next. The jack-o'-lanterns, so chanterelles are completely edible and delicious on your right-hand side. The jack-o'-lanterns, which is a Clatosabe species that you see on the left, are common. These are common mix-ups for them. Chanterelles, excuse me, between these two of them, I don't have a really great way to help you identify the difference besides the chanterelles tend to look like those like elephant ear kind of, they're like in a half moon shape, real fanny. And then the jack-o'-lanterns you can kind of see look like they have a stalk. But they can be really difficult to tell apart. There's not a whole lot of bright orange mushrooms in the world, and both of these are bright orange. Next. These are just a couple examples of Inosabes. Next. These are quaternary compounds that don't cross. So these have muscarinic effects. So what are the muscarinic effects? What are cholinergic effects?
Or like tearing up.
Yep, lacrimation.
Urination.
Defecation. Salivation. Perspiration, all those things. So you get, but they don't cross the blood-brain barrier. So what would you not get?
Like sleepy.
Altered mental status. Typically, they aren't altered at all. So they get the peripheral effects. They're puking, they're urinating, they're having just diffuse diarrhea. And none of the nicotinic acetylcholine receptor effects. So what are nicotinic symptoms? What medication do you use that have nicotinic anticholinergic? No. There's one medication in particular that we use in the emergency department all the time when we're intubating people.
Oh.
That's a nicotine agonist. Succinylcholine, that's the one. So what happens when you give people succinylcholine?
Paralyzed.
How? Why?
All their muscles, like their NMJs, you're blocking their.
You agonize so much to the point that you can't relax.
There you go, kind of. So are they stiff when you paralyze them? Not that you can't relax, because that's an ATP thing. So what have you guys ever seen anyone get succinylcholine? What happens first?
The muscle fasciculation.
They fasciculate, right? Unlike rock works differently, rock uranium. So they fasciculate, right? Because that's you're activating nicotinic receptors for a little bit, and then they become so agonized that then you get muscle paralysis. Similar with nicotinic things. So if you get into enough nicotine, for example, kids who drink nicotine liquids, they'll have nicotinic symptoms. So you can get respiratory muscle paralysis. So we don't see any of that with these mushrooms. So no nicotinic symptoms, and also does not cross the blood-brain barrier. So everything is peripheral. It also doesn't get broken down by the typical enzymes that break down the acetylcholine. So it might be long lasting, long story short. Next, treatment, supportive care, atropine. How do you dose atropine for a organophosphate? What's the ACLS dose of atropine or bradycardia? You got to know this. One thing you have to memorize besides your mom's phone number. Milligram, yep, 0.5 to 1. So these we start with typical doses. How about if this was an organophosphate, where would you start? What dose? Higher or lower? Higher, right? So we typically start with like 5 milligrams of atropine. What's the maximum dose of atropine you can give a person? Total trick question. It's just based on vibes, right? So there's no such thing as a maximum dose of atropine. So for organophosphates, because you get a lot of bronchuria, you might get some bronchuria with these, but typically not. We'll dose 5 to 10 milligrams at a time, and you're titrating to drying of secretions, which we do here. Typically, we can start with doses like 1 milligram here. So you're really titrating to drying secretions for these patients. So if they have any amount of bronchuria, so they're coughing up pulmonary edema, we're going to keep dosing atropine until that dries up. Typically, they don't get real bradycardic. They might. What happens when you give somebody a bunch of atropine to their brain? Does it cross the blood-brain barrier? Because the mushrooms don't.
Yes.
Yes. So what happens when you give somebody like 3 of atropine? Maybe. They might get agitated and altered. So it's just an important thing to keep in mind. So the more you can give them all the atropine you need, just be ready to treat that delirium that might become with it. Cool. For 2-PAM, how does 2-PAM work? And who do we give 2-PAM to? Pralidoxime. We don't use obidoxime in our country. They might in Australia, I'm not sure. Oh man, this is like digging up some, like, it's sitting right here. Kind of, you can. For myasthenia gravis, like crisis, you can do a test, a cholinergic test.
Organophosphates?
Yes. Why?
It regenerates acetylcholinesterase?
Kind of. It helps prevent the aging process. So remember, eventually those organophosphates, not carbamates, but organophosphates will bind irreversibly to the ACEH, the acetylcholinesterase. So in this case, we're not worried about that. So there's no role for pralidoxime in here. So even though it looks exactly like an organophosphate, we don't need to give things like 2-PAM because it's not that they're going to undergo an aging process. Does that track? Everybody remembers that? There's like, we all use the same graphic of like, looks like a box, the ACH, and then it like hydrolyzes and binds. Double bonds are hard to break. Cool? Okay, next. That's how I remember it. So it looks like they look like little upside down umbrellas, and then you're singing in the rain. Okay, moving on. All right, these are fun. So who's that? Does anyone know what that kind of mushroom is? It's very common in like everything. Children's stories, they're bright, they're colorful. Does anyone know the name of this? So these are Amanita muscaria or fly agaric are the other ones. Go to the next slide. There's a bunch of different varieties of this. They usually don't look as pretty in red. That's like AI. Pretty in red is that. On the left-hand side, so there's Amanita muscaria. There's Jamata on the right that look orange. There's a Lepiota species that looks a little more orange. So the little speckles on top of this are remnants of that universal veil. As that pulls away, it leaves behind those little speckles of white on top of those. Go to the next slide. These contain each single mushroom and each species of this genus will have varying amounts of ibotenic acid. And Dr. Kate says mucimol, I say muscimol. I don't really know which one is correct. We're going to say muscimol because I'm here. So each mushroom will have different concentrations of these, and each species will also have different concentrations of these. So the ibotenic acid looks a lot like glutamate or glutamic acid that then gets metabolized to GABA. Muscimol and the ibotenic acid, gets metabolized to mucimol or muscimol, which is very much a GABA agonist. I got those reversed, I feel like. Yep, I got them reversed. Sorry. The mucimol, much more GABA activity. Ibotenic acid is very much closer to an NMDA agonist, which kind of looks like an NMDA antagonist. What NMDA antagonist do you know? Ketamine. So some altered mental status effects with it. Go to the next one. So it depends on who you are, what kind of effects you're going to have. For whatever reason, and I can't explain it to you, adults will typically be more sleepy and have more GABAergic symptoms for some reason. Pediatric patients, and I can't tell you what age this flips over, teenagers, I suppose, will typically have more excitatory transmission, so more of that glutamate sort of activity. They almost look like they got a bunch of ketamine. So the adults will usually just look intoxicated, like Babar looks intoxicated. The children, though, will have a little more hallucinosis. So when we've had families that have come in, had ate the same thing. We had a guy who took a bunch of Amanita muscaria and put it in a bottle of vodka to make like I'm not sure, I can't answer that question, but we found him on the beach. We found him on the beach in San Francisco with a bunch of this sitting in vodka, but again, he'd also drank a bunch of vodka, so what do you do with that? But then we also had a family that ate a stew of mushrooms that included some of these. All the kids were running, agitated, hallucinating, and the parents all just looked intoxicated. So it was very interesting. You can kind of see that play out. But each mushroom will have different concentrations of these, and then everybody will look a little bit different. So it's a little difficult to predict what people are going to look like for these. Treatment is just supportive for these. Go next. Most importantly, you don't trip balls. What do you know about these mushrooms?
Magic.
Who are these guys? These are magic mushrooms, right? So these are the psilocybin-containing mushrooms, and they're all just the psilocybe genus, I suppose, and then different species of them. Go next. An important part of the magic mushrooms. So how do most of us interact with these kind of mushrooms? Are they fresh or are they dry?
Right.
Usually dried and or powdered. Everybody is familiar with how to use a mushroom, like in cooking. So you can cook with them, you can eat them, people make teas for them, you can powder them, you can make they start coming in pills now, so that you can change your dose, microdosing. There's a lot of research behind these now. The legality and the criminality of these are differing in different states. So they are legal and decriminalized in certain states. Here, I believe they're still criminalized. When I say here, Louisiana. In the wild, when you pick these, they bruise quickly. So as soon as you pick the natural mushroom and it's fresh, it'll start to get these blue bruises on them immediately. Again, I'm not telling you this so you should go find them, but should you find yourself in a place, they'll bruise easily. So brown on the bottom, brown caps, long stalks, bruise easily. The tricky part about this is pretty much every other mushroom that'll just make you puke your guts out also looks exactly like this. So it's a gamble. You could trip balls or you could just puke your guts out. Your day is up to you. Next. Tell me about, so these do not typically cause hallucinations. So true hallucinations, when you see things that are not there, are actually very rare with psilocybin-containing mushrooms. Typically, it's just illusions. Will you go to the next slide? Did I include all that stuff? So some people will have just illusions. Palinopsia is when you see things when people have trailers and stuff like that. So if you watch the center, you'll see green pop up unless you're colorblind. Oh, sorry if anybody's colorblind. Synesthesia, you guys remember what synesthesia is from neuro? What's synesthesia?
One sense. Yeah.
They get confused, right? You see sound, you hear colors or something like that. But true hallucinations are rare with these, and it's typically a serotonin effect. So what happens when you get a bunch of dopamine to people in general? What kind of methamphetamine, for example, has a ton of dopamine? That's when you typically see hallucinations, psychosis, that kind of thing, which is why for things like methamphetamine that has a ton of dopamine release, we see more psychosis associated with that. And that's why our antipsychotics, quote unquote, are typically antidopaminergic agents. Serotonergic effects are a little bit different in that they're enactogens. So MDMA, for example, has a ton of serotonin effect. Enactogens meaning you have a feeling of belonging and like love and stuff like that. These are typically just illusions and not typically hallucinations. Go to the next one. So you can see some GI effects with these, and typically people will just have, like I said, illusions, synesthesias, maybe a little bit of ataxia. These people will typically not have a real big adrenergic effect, so they don't tend to get real tachycardic, hypertensive, like you would, for example, with methamphetamine or cocaine that has a lot more catecholamine release. If somebody's like hypertensive or tachycardic, it's usually because they're freaking out about something. So the treatments for these are typically just like a quiet, calm, dark room, which is a little tough to simulate in an emergency department. So these are people where I'll usually try and find like an actual room with a door that closes with lights you can turn off. In our emergency department, we have those rooms that have cameras so we can see people. It's a perfect place for them. Turn the lights off, just quiet. Benzodiazepines are going to be your drug of choice for these people. Do advance one more time. I don't remember if I have another slide or not. Nope, go back. We typically avoid antipsychotics in these people, so things that are antidopaminergic. There's this theoretical sort of prolonged sort of a hallucinosis that's described with these mushrooms when you give people antipsychotics. It's a little difficult to sort that literature out because it's older, but typically we'll stick with benzos and avoid antipsychotics for these people if at all possible. And then a quiet dark room, very much the same with people who are using LSD, acid, PCP, that kind of stuff. People that are hallucinating or having illusions, like just reducing their sensory experience is usually the best thing to do for those people. So when we have kids who come in, kids being teenagers typically, who come in just tripping balls on these, we just like put them in a room, turn off the lights, and then they wake up a few hours later. That's pretty much it. All right, so those are our main mushrooms. There's like a bajillion other species. There's some that cause rhabdomyolysis, which is really cool. There's some that cause all sorts of other effects. Renal failure without rhabdomyolysis is really creepy because it's delayed and you can't really predict who it's going to happen to. Love that. You get renal transplants. So don't go forage mushrooms. Everything is edible once. Just once. Okay, questions? What? Yeah.
So I guess like in the ED, patient comes in, would the pattern of determining whether or not it would be like a mushroom related ingestion, would it be the sudden onset GI effects that eventually will resolve or does resolve, and then the neural effects or the side effects?
For which mushroom?
Or just, I guess, just in general, if for you suspect, like, or for you to put mushroom ingestion intoxication on your differential?
In our differential? It's a really good question. When there's no history, it's really difficult to then identify. So it would typically be once we start to see a pattern that we expect for a mushroom. So let's say that we have somebody who comes in with nausea, vomiting, diarrhea. There's not, on the top of my head, Amanita phalloides for that person because there's 9 million things that are more likely. If that person were then to go on to develop hepatic failure for not really a good reason, and we saw, for example, a biopsy that looked very similar to that, hepatitis, all the other things are negative, then we might be suspicious of it. The bummer part being, again, we don't have an effective antidote anyway, but then typically we're just doing supportive care. So those are difficult when there's no history. When we have a history of an ingestion, the other thing that's important to know is when people ingest it, how many mushrooms did they ingest? So for example, if you have a stew that's a mix of mushrooms, you could have a mix of mushrooms that cause early GI effects, late GI effects, and that kind of thing. So those are difficult. So some people would say like, oh, if they're puking within an hour, it's not a phalloides, but if there's a mix of mushrooms, you don't really know. So those people will trend LFTs to see kind of what's going on.
Thank you.
So, and you had a question too.
Yeah, I was gonna ask, how frequently can I actually give you a history of like exactly what they ate?
Pretty frequent, especially for children. So a lot of times the parents will be like, we were out, the most common thing is we were out in the yard, I turned around, I turned back, my 2-year-old was holding a mushroom in their mouth, and we'll usually get a picture of like a partially chewed or part of a mushroom. And typically we can at least get to the point where we can identify the color of the gills, and that can help us triage them. And that's a very common poison control call.
Yeah, I would ask, do you only get toxicity through ingestion, or are there like types of mushrooms where handling and or like spore exposure?
Handling are fine. As far as we know, spores are fine. I've never heard of anybody who like licked a spore print, which wouldn't it be unreasonable? Like kids do everything. Like you're like, how did that happen? And you're like, okay, like for my kids, I'd be like, yeah, obviously they licked a spore print because like gross. Or an animal would be another one where they might, I don't know, lick it. But handling them is fine. We always recommend you wash your hands, but I'm not aware of any case reports of someone who was like handling a mushroom and then like licked or ate something and then they got sick. Some of them, when you inhale the fumes, you can get some symptoms. Typically it's not enough to get really sick, but like the gyrometra, for example, they might get some delirium or ataxia or something like that. So.
Is there any co-ingestions that you see pretty frequently that makes it maybe worse?
There's another species of mushrooms called coprines or inky caps, which cause a delayed disulfiram reaction. So you can eat them and you're fine. And I think that they're good. I think they taste good. I don't dabble. But you can cook them and eat them and be totally fine. But then if you have a glass of wine 2 hours later, then and everyone knows what a disulfiram reaction is. There's part of pharmacology. So then they start puking and getting hypotensive, and if they ate enough and then flushed. So the coprine species, the most common co-ingestion with all these is just alcohol, because people are typically eating it. So that would be one example. That's the most common example of a co-ingestion. They're so interesting. What's up?
So like like a resident was mentioned it during like resident didactics. So amatoxin is like a very common thing to show up on like EM boards. Like when would you throw NAC on a patient? Would it be after, like during the quiescent phase?
If the minute they start vomiting, the second that we have any concern for it, then we'll start NAC. Does it help? Who knows? So
like how much mushroom ingestion do you see here in the Ochsner system?
we don't see very much mushroom ingestion that comes in to the hospital. We don't take home calls. So we're not poison control. So we don't take calls from people, just the public. And the nurse line just sends people in. So how many calls poison control is getting statewide, I'm not 100% sure. Once you start driving home, you'll see like if you're in New Orleans, you'll start seeing all these giant white capped mushrooms. They're a different species, the name of which I'm forgetting, that are not Amanita phalloides, but look very similar to them. So you can just tell all your friends they're phalloides. That's what I told my nanny and she freaked out. It was not nice. I didn't want the kids to eat them. Okay, other questions? We're gonna move on to next door. Dr. Sessions will introduce himself. Give us 2 seconds to make sure it's set up, and we're gonna do our escape room. We don't have the sim center, so we couldn't actually do rooms. So we have 6 tables. So divide yourselves up into 6 groups, however those numbers work out. And then once you find your groups, the most important thing is a name. And it's got to be a good name. So like, let's not, this is, again, you guys know, this is high on my list for good names. Other questions? Real quick. Okay, so divide yourselves into 6 groups. There might be uneven numbers, doesn't really matter. And then think of a good team name, and then we'll come grab you. Good? Okay.
And I was at LSU, and she's leading up, I see, obviously. She's representing LSU, I love it. We got some heavy hitters. You got Mark here. Very cool. You got the volunteers. I'm sure the Clemson Tigers want to get this show on the road for their game later on. Is that what they're doing? They're like, come on, let's get this show on the road. Very cool. You got some Razorbacks going on here. Look at Lauren, very cool.
Not going well.
So you guys, do you want them to start introducing themselves and stuff like that? So I kind of started. I kind of said.
So, hi everyone. Thank you all so much for logging in to our program director panel portion of the symposium. It's our 7th annual one, so we're really happy to have this. In person, we have Dr. Swao, who's the Ochsner AAEM Residency Program Director. And would it be okay if we have our program directors online to kind of, in any order, introduce themselves and let us know?
Because everyone are coming in.
True.
Yeah, you start picking on them.
Okay.
It's all right. You can pick on the program directors. They won't know. I promise.
How about Dr. Evans? Could you please introduce yourself and where you're from?
I am Lauren Evans. I am the program director at University of Arkansas for Medical Sciences. We are located in Little Rock, Arkansas.
Very cool.
Dr. Ryder.
Hey, Mark Ryder here. I'm the program director at University of Tennessee, and we are located in Murfreesboro, just outside of Nashville.
Dr. Leaf, please.
Howdy, y'all. I'm Jed Leaf. I'm the Associate Program Director here at UT Southwestern in Dallas, filling in for Dr. Williams, who is off on some SAEM business. So happy to be here. Proud graduate of the LSU Emergency Residency in New Orleans, and my wife's a proud graduate of the OB Residency at Ochsner. So a lot of ties to down there. Y'all trained in a fantastic place.
Thank you so much. Dr. Wilson, please.
I'm Jessica Wilson. I'm program director at UT Health Houston. We're really excited to get to talk to everybody today.
Dr. Pathman, please.
Yeah, Dr. Pathman, I'm one of the APDs at ECU in North Carolina, and the IT folks just fixed my computer and took away the Zoom video permissions, so I will try to get that working shortly.
I'll try to troubleshoot that in a bit. Thank you.
I think it's my end, not you.
Oh, okay. Dr. Griffin, please.
Yeah, I'm actually also having trouble with my video. I only have audio for some reason, but I'm Dr. Griffin. I'm one of the LSU emergency internal medicine faculty. Unfortunately, Dr. Martinez, our program director, couldn't be here today, so I'll be representing our program.
Perfect. Thank you so much for being here. Some of my view was cut off, so if there are any program directors who I haven't called on, please feel free to jump in for me. Thank you.
Yeah, hey, this is... Oh,
good. Sorry. No, go ahead.
This is Chris Gallivert. I'm the program director at UT San Antonio. Also trying to figure out why there's not a video option for me on this Zoom call.
Thank you so much.
This is Samir Desai. I'm the program director at the University of Kentucky, and I'm feeling a lot better knowing I'm not the only one who doesn't have a video option. So thank you for having me, though.
Hey, everybody. I'm Dr. Bush. I'm calling from Charleston, South Carolina, representing the Medical University of South Carolina here. And I also have not shaved today. So this is actually a good thing that I don't have video. So,
I love it. I agree. I mean,
I'm glad to join you guys.
At least for me, I wish I didn't have a video. You don't want to see my bald mug on the film.
Hello, everybody. My name is John Camberin. I'm going to join the non-video club as well. I'm calling in from the Christus Health Texas A&M program in Corpus Christi, Texas. I'm filling in for Dr. Tomanek, our PD, who's got some clinical responsibility today, but I'm happy to be here.
And I'm Melissa Smith. I'm one of the APDs from UT Southwestern. I am also the no video. I'm happy to be here.
I didn't get that at all. Sorry, I think we're having some technical difficulties there. What was the last one? Lies, yeah.
Hi, Joshua Solano calling in from Florida Atlantic University. I'm the Associate Program Director, and I'm filling in for Dr. Lisa Clayton, who is enjoying New York with her daughter for her birthday. So, more important.
I think I figured it out, guys. I will work on this while we go through some of our questions. But first off, we'll ask our students who are here today, do you have any and all questions for our great program directors online or for Dr. Slough here? We'll first kind of open the floor. I know it's a big, ask, but I have backup questions in case, we can't think of any right away. Oh, yeah.
So how do you like residency caps? That's a question?
So like I know the date has already been passed where people submitted the applications already been sent out. What would we do if we found a program that we like? Do we have to resend out or like cold email somebody to let them know we're interested and that we sent another application out?
So the question you're asking, again, I don't know, I'll let the panel, if you guys want to answer it. The question you're asking is, you have a deep interest in a program.
Yeah.
You did not signal them? Is that?
Well, not signal them, but like let's say I sent out another application like later.
Okay, so like you submitted your first batch,
right?
And then you did a follow-up.
Right.
How should you deal with that component afterwards to make sure that program is looking at your application?
Correct.
Anybody want to go for it? Mark, go for it.
Yeah, so I would say the key thing is that you want to get that application in as soon as possible. If we get that application in over the next week or two, really before November, I think we're still going to think you're pretty serious about things, especially if you send a personalized email that might be noting if you can come up with any sort of particular reasons why you're applying to the program. Then I think that'll be fine. Once you get to like November and you start applying to programs, and I think they're going to think you're a lot less serious about their program in particular. And it's really that you weren't very pleased with the number of interviews you've gotten so far. So I don't think you're behind the ball if you do it real soon, but another 2 weeks or so, and you're going to definitely be viewed as not being serious about the program.
I'd like to second that about the particularized interest. One of the things that applicants don't think about is that we as program directors are also not interested in having unnecessary interviews. And so if we know someone has a unique particularized interest to our program, we're going to view that as a worthwhile interview, even if we didn't initially communicate that in your application. And so if program directors know there's a definite reason that you're taking them seriously, they're going to be a lot more interested in interviewing you.
And if you are going to send a personalized email, make sure that the email is like actually personalized. We tend to see a lot of like interesting formatting things that happen when you take the Dear Dr. Blank that is in one font and then paste the I'm excited for being in a urban high acuity blah 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 that you've sent to like literally everybody and just hit like Control V 22 times. So I would definitely recommend if you're going to try to send something personal, then make it personal.
I agree, Chris. I actually delete all those generalized ones. I don't look at them at all. But if you send me a personalized email and you tell me why you want to go to Arkansas or South Carolina or UT area, whatever that may be, and there's a little bit personal touch to that email, I think that goes a long way, so I agree.
Sincerity shines through.
Yes, love it, Josh, I agree.
I'll add one other option that I see that I do take more seriously is when another clerkship director, program director reaches out and says, "Hey, I've got a student who applied late, but is really interested after hearing more about your program," and that certainly is something I read more carefully.
I love it. I agree. I think we want to make sure that it's a right fit for both of us. And we're going through tons of applications. Right now, you guys are in the driver's seat. You guys are able to apply to all kinds of programs, many more than when we were used to do it in person, because you can't afford to fly and go to all these places in person. So we recognize that too. So there's nothing wrong with you. If you applied a little late, but not too late, is that kind of is you sharing your story. Hey, my wife, my family, and don't make something up. Be genuine about it. So I agree with what all of them said. And correct me, all of you guys, if I say something inappropriate. But yeah, I agree. Other question? Yeah, Charlie.
Thanks everyone for being here. I don't know if you can hear me okay, but I was wondering how to navigate this interview season, moving to kind of going off what we were just talking about to virtual interviews. How can you establish a connection quickly and like really get to know if a program is a good fit, or on your guys' side, if an applicant is a good fit, just virtually?
Yeah, go for it, Jed. $1 million question.
So that's a tough one. We struggle too, because really, the interview is you want to know us, we want to know you. I think a lot of our programs, we offer the pre-interview kind of dinner thing that's at least a little more informal setting. I would say 100% go to that, get a feel for how the residents kind of hang out, and get a feel for that. And then, it's going to sound super cliche, but you really just kind of have to be yourself, just smile, be friendly, be open, may have to be a little more extroverted than usual, maybe crack open a Red Bull if your Zoom background will let you do it before your interviews.
I love it.
I think it's just kind of, be yourself and try to put on your best face. And then, for me personally, I'd say, get a feel for those programs, and then we're all going to offer, not probably all of us are going to offer second looks. And you may have to just say, hey, okay, I'm going to have to hit a couple of these to really get a feel or a vibe. I think a lot of our programs probably also will have ways that if you happen to pass through Dallas or San Antonio or Houston, there's probably a way to run into a resident or one of our chiefs and kind of get to meet a couple of our residents in that neighborhood too. Certainly not required, but I think if you're really trying to feel out, hey, do I want to be here? Do I fit? It's another way to look at it. But I think really the pre-interview dinner is key. Definitely hit that. So that's my thoughts.
Good.
I agree with that. And I think it got said about the emails, but the sincerity really does shine through even on Zoom. We want y'all, we know it's going to be part of your prep to kind of rehearse some of your answers. And, I think that that's great. You should rehearse your answers and make sure you're saying what you want to say about yourself. But there is a point where there's a fine line between rehearsed and false. And so make sure that you're letting us get to know you with your answers. We recognize that this is a huge anxiety-provoking thing for y'all. Y'all are about to make a huge decision about the next, 3 to 4 years of your life. We don't want you at a place that you don't want to be any more than you don't want to be at a place that you don't want to be. And so there really is benefit to you as the applicant and to the residency when y'all get to know each other for who you really are, because so much of this, you're going to get great training at every place on this panel. You are going to get out of residency what you put into it. And so it's really about finding the right space for you to, fulfill your potential. And it's hard to do on Zoom, but the more authentic you are, the best chance you have of that happening.
Yeah, I agree. The vulnerability of it, and actually you looking a little bit in anticipation about those programs, and you showing that you've learned a little bit about those programs before. It shows that you're not just showing up, that you're actually truly interested, and that's important. What do you guys think? Yeah.
Yeah, to echo those earlier comments, I totally agree that, trying to engage with the residencies in a lower stress environment like those pre-interview dinners. A lot of our social media accounts are run by the residents. If you want to reach out and message us through those to get to know the program a little better and demonstrate interest. And then, there's a lot of time between now and when you have to finalize a rank list. It does not have to be a formal setup and meeting time. Whenever you're around, you can stop by. Plenty of us will meet you for dinner, let you into our academic conference centers, etc.
Completely agree.
All right, that's pretty good, right?
Yeah, I think so.
Other questions? Go for it. Alex.
Yeah, so some of my slow letters will be rolling in by mid-December. I'm wondering what disadvantage that is, how important it is to have just maybe one slow during the September application, and what's the best way to get them to you after the fact?
Let us know.
That's a tough one. All right, guys, go for it. Josh.
Yeah, I mean, having slows earlier than later is going to be beneficial, but if it's going to be rolling in later in the interview season, send an email, let someone know. What a great way to remind someone that you're serious, that you care about this program, and that you've still been working your butt off. I think uploading it into Residency Cast and sending an email is a perfect pair.
Yeah, I don't think it's a big deal. I think the big issue is if you have no slowies early on, then there's a lot of program directors that aren't really going to take their application seriously. They're going to kind of hold off on a decision. Where if you have reason to think you have one slow and you have reason to think that it's pretty crappy, then it's pretty important to get a better one going. But if you've already got at least one and you think it's reasonably okay, then I don't think you're at any significant decision.
But I usually tell applicants that do have a slow that's coming in later, not only to notify the program that it's coming, but once that slow is actually sent and you know that your letter writer has sent that in, be sure and let the program know, just to circle back around. One of the good things about Residency Cast is we are able to tag your application, and I'm sure many programs do this to kind of notify. We put a tag on your application to say you have a slow pending, but it's always a good idea, I think, to circle back around with the program too and just let them know, hey, this is in, just wanted to be sure you saw.
Yeah. I like what Melissa's saying too. Sorry. Amir, go ahead. Sorry.
I think, the key mark is just at least having one in before, it's open to the programs, because if you get looked at and there's no slow there and, then you get moved on to a pile of incomplete, all interview spots may fill up by the time, you get back and looked at around, and then that kind of opportunity is gone. I think emailing specific programs of interest is a smart move once a letter is uploaded. But again, if you get through and there are just no more interview slots, it's just going to be on a wait list basis, and that's a really tough spot.
Yeah. And then what I was going to add to Melissa is when you're emailing us as a program director, always CC and email the program manager or program coordinator. There's a lot of things going on during this time. So you making sure that you email a couple of the people there to make sure it stays on top of, because we do get a lot of emails and a lot of things going on academically and personally and all kinds of stuff. So just assure that happens. That happens at least to me. I always tell everybody, please CC our program manager. Anybody else about the slowy, the late slow? It's a tough thing. But I agree with what Mark was saying. At least having one, it helps us understand where you are, how somebody has objectively seen you at a different institution towards the beginning of the application season.
One additional comment on that, Residency Cast does allow you to put your future slows in. And so some students have already done that. And so it is nice for us to be able to see maybe they have 1 out of 2 slows. And so I know something's coming, and that gives me also the intention to mark an application as it's incomplete. I expect more information to come in from this student in the future.
All right, we got another one? Any other questions? Oh, yes, my God.
I think a lot of us know what like a good, well-rounded student looks like, but what do you guys think is too much? When do you look at an applicant and say like they're all over the place, they're too much, this is a bad sign?
Like you put adding like being a Cub Scout and brownie or something like.
I guess just in general, like is there a point where it's too much, or you think a student might not even know exactly what they want? Like, am I explaining that
What's
correctly?
too much? That's gonna be
What's
a
too
tough one.
much? Yeah.
Let's see what everybody says. I love this question.
Yeah, from my perspective, there's no such thing. Being involved in different stuff is great. Taking on leadership opportunities, service opportunities, those are great. We don't expect you to have it all figured out during medical school. There's nothing wrong with exploring different things. So I can't think of a time where I'd be less impressed because there's more stuff. So yeah, I don't think you have to worry about that.
Yeah, I would agree with Dr. Ryder. There's no such thing because we all have ADD anyway. We're all over the place. But I think that if it made an impact on your life and your future career, then yeah, we're going to look at it. I look at the times committed to the certain events. In other words, if you spent 1 hour in 2021 doing something, that probably doesn't mean a lot. But if you spent, 10 hours a week for 2 years on something, that obviously is going to stand out. So I would pick and choose, but if it made an impact on you, then we want to know about it.
And I think an area to be careful is the forward thinking lack of direction or infinite directions. And if you love pediatric emergency medicine and you love EMS and you want to combine those two in a specific way, I think that's wonderful. If you have 7 interests and you talk about how you want to bring each one of those to life in your career going forward, it can paint a picture of someone who may not fully understand the role they're trying to step into. That's the only place that I've ever felt cautious about someone's disparate interests, because yeah, we're a bunch of ADD doctors out there having a great time.
Like as you put yourself together, you can put as much on your application as you want, but you should also think about like, what is it that you're trying to tell us about yourself by putting that thing on your application, right? You're trying to introduce yourself to us even before we meet you. And so I think it's not necessarily the quantity of things, but the picture you're painting about yourself, the things you're trying to tell us about you and what your, interests and passions are, that kind of comes together.
That's the word. What are you passionate about? How can I make a connection with you? So like if I was a Boy Scout and you mentioned something like that, you're an Eagle Scout and things like that, well, that's a connection I made. And it's something that was valuable to you and it helps you understand those things. But what she just said about passion, what drives you, what interests you, and like Jeff said, several hours you spending in fixing a boat, obviously you're really interested in boats, as opposed to, you're just gonna hang out watching a movie once every couple of years, and obviously that person's not into movies.
Yeah. Okay. Thank you.
Yeah, I think one place where that comes into play is the personal statement, which, is where, I think, if you go over really the one page, I always tell my students that I'm advising to really keep it to one page as opposed to going to like 2 pages, unless there's really some, really unique circumstances. I think keeping it to 1 page on the personal statement is a smart move, just because we are all a little bit, kind of moving through fairly quickly, and then we're like, well, what are the key points here, as opposed to the person who's kind of long-winded. I don't think that helps in an EM application, but it's my 2 cents.
Yeah, and if you're going to list interests, make sure they're true interests and passions. This was kind of echoed here earlier, because if we ask you about it and you can't tell us much about it or why you're interested in it, that could be a little bit of a red flag that you're just listing everything that you thought you should have on an application.
We ask about the thing that we're most interested in too, and we're probably going to know about that thing we're asking about because it's exciting to us. And yeah.
All right, awesome. Go ahead.
Hey, thank you guys for doing this. So my question is, I know a lot of us probably have applied to a lot of the programs here. What does like a good fit for your program look like? What are you guys looking for in your ideal resident?
That's a tough one, guys, because everybody gonna have their individual looks.
Yeah. Yeah, I mean, I think personally that fit is kind of another F word that people use too much. Because at the end of the day, I think that if you rely sincerely on fit alone, then you tend to kind of include a lot of bias into kind of how you perceive something or how a group of people perceives you. You know, what we really care about in San Antonio as a county hospital is people who are really dedicated to taking care of, you know, a specific patient population. And so, you know, when I think about fit, I think about more of fitting to like what our mission is and not necessarily like who we are personality wise. Because I think that in every group of residents, you know, it is very helpful to have a lot of different personalities that are very different. And so it is very helpful to have the big introverted research heavy person who really brings out a different side of the other people who are in their residency class. You know, I think if we all had, you know, like the Glockenflecken, like bicycle character, and we had 13 of those per class, I think it would be very challenging for all of us.
Just to echo what Chris just said, I think for the most part, you know, relatively boring a resident is actually a safe resident, and most of our residents, that's what we're looking for, not someone who's particularly eccentric or unusual or, you know, what might be perceived as interesting. You can handle a couple of those, but you can't handle a class of those. And so oftentimes, you know, I think that's kind of a difference in what a student might think we're looking for versus what we actually are looking for.
And that fit, I think, is even more important from the resident side than from the program side. And feeling the energy, or especially maybe a lack of fit. If you're speaking with the program, do these people feel like those I can be a learner, a worker, a doctor, that I can be vulnerable, that I can have a struggle around or with? And if they don't feel like your people, I think that's the biggest consideration of fit going through all this. But I know it's not it's not on our end. That's a personal one for you all.
I think the point Dr. Desai made is very good too. We sometimes forget that we're interviewing for a job and not a cocktail party. So the purpose is not to be the most entertaining or interesting person in the room, but to convey why you want to be there and to leave the impression that you're a solid, grounded person that's going to take care of their business when they get there.
That's what made The Office so good. Those secondary characters are one who kind of blossomed over the seasons. You love them just the same at the end. You need that diversity of personality, of people, of focus, of love and attention.
Yeah, I would agree with that as well. I'm not looking for a significant, cookie cutter type of person. I'm looking for what I believe is going to be the best person to become a really great emergency medicine physician. So yeah, as long as you're not too flowery out there, we're looking for just good, hardworking people.
And I think also, and correct me if I'm wrong, you guys, the applicants looking at your hospital and the type of community that you serve is also helpful, because you can see where that hospital is situated, what the community that hospital serves. I mean, the perfect example is across the street LSU and Ochsner, not necessarily exact same patient population. So I think it's something that you try to find out a little bit about them, about us, all of us. I think it's really helpful, and why you want to be part of that and that vulnerability.
I'm gonna hop
looking.
in. Go ahead.
Sorry, Jess, go ahead.
You go ahead.
Y'all are asking, how do y'all find out, if you're the right fit, but at the same time, y'all are trying us on, right? And I put it in the chat. Everybody wants to know that the vibes are on, but those vibes have to be based on values. And so you should be looking for a program that leans into the same values that you have, right? Is it the patient population that you care about serving? Is the outreach that they're doing in line with the values that you care about. Because, you know, residency is hard, but emergency medicine, like this thing that we do, is not easy. And to have sustainability in residency and in this career, you really have to be able to reach down back into those values and the why of why you did this in the first place, you know, to get you through some of those hard days. And if you're at a place that, you know, maybe didn't really match the values that you cared about, it's harder to get through those tough days, right? When you're with people and in a place that you're all working towards the same mission and on the same values, that really does get you through in a lot of ways that maybe we don't talk about enough.
Correct. All right, Sarah, go for it.
Yeah, I just wanted to hop on because maybe I'm the only representative of a combo program here, but so I don't know if there's any interest in this group for doing a combination program, but the IM EM program and the EM PEDS programs are both 5 years. And so I agree with everything that everyone is saying about, you know, what a fit means for us. I think we're all looking for people who are going to be a good fit for the mission of our program and the mission of our institution. Additionally, because our programs, the combination programs, are so much smaller, we're really looking for folks who have a clear desire to do a 5-year combo program. And so sometimes every year, a certain percentage of our applications are backdoor applicants who are maybe trying to take a backdoor into either emergency medicine and less so internal medicine. And so for us, it's really a non-starter if the personal statement, all of the SLOEs, all of the letters are just geared towards one program or another. And so really thinking about why you want to do a combination program, that really matters to us. And again, I think what people were saying before is if you're late to making a decision either to coming to EM or you thought you were all EM and then you really liked your IM rotation and so you didn't maybe get an IM letter, that communication for us especially is, you know, by email, reaching out maybe for a phone call, just expressing that personal interest really means a lot to us. And I think that's the case for most of the other combo programs as well.
All right, any other questions?
So I guess this goes more towards the 3-year programs. Does the transition to 4-year programs affect our education or training in residency?
Nope.
Not at all.
Nope.
You start as a 3-year, start as a 3. Whatever happens, so we don't know what's going to happen in the future. Well, you'll go into that. And correct. You guys can jump in. I'm just kind of if you're applying to a 3-year program, you will graduate as a 3-year program, irrelevant of what happens in the future. Same thing for a 4-year.
That's at least how I plan to do it, and I don't foresee like changing the 3-year schedule just for some sort of transitional purpose. So yes, good question though, because I think at this point we don't even know exactly when that's going to happen, and even all the exact changes that are going to happen. It's all still proposal at this point.
It's also kind of like there's some programs that have flight integrated into your residency. It's just part. You need to know before you show up. That's going to be part of it. That's something that programs need to make sure they say. And if you're applying to that program, you should really know that they're heavy or they're passionate about X, Y, or Z. That's going to be part of your curriculum.
We're starting to do some planning for some of the possible incorporations. And so I honestly think it would benefit anyone that might have an interest in some of those things that we'll have planned and potentially have available for electives by the time they get to being a 3rd year. So I think maybe benefit you, but it's not going to change what we're telling you now is going to be your course of education over the 3 years.
And I haven't heard anything. Have you guys heard anything? Because I haven't heard anything. That's still kind of up in the air. So nobody knows what's going on until it happens. And it'll probably be the day before. So that's usually kind of how it occurs. All right, any other questions? You guys can ask questions or just kidding.
My question is relevant to what Dr. Wilson was talking about, values and really finding what a program's values are and that you align together. I'm still in my third year, so I haven't delved into looking at specifics about programs yet, but from a couple that I've looked at on their website, I find that sometimes they're very broad and generic, like we love serving the underserved community, or I don't know how to get more details about their values sometimes through their website. Is there a way that I can better know about a program specifically, where and how?
Good question. You guys? I think Jessica was going to go in there. Yeah, go for it.
Yeah, I think you got to check out the resident run socials.
Perfect. Yeah.
And if you have the opportunity to go to a conference and speak with representatives at one of the stations there, or one of the many kind of put on sessions sort of like this, but that tend to be on a breakout room, smaller scales, more regional, where you can just speak one-on-one with a PD, more in a conversational instead of a Q&A. But yeah, it's hard because everyone likes helping people and taking care of their community and being a loving and supporting environment and providing good education. Like that's, I hear you.
I also think that doing research about the institution that the program is housed in, I came from New York. It was a shock to come to the South, but I came here because of the really long-standing history of public health in Louisiana, and the legacy of Charity Hospital, which I, rotated here, and then I heard about, and then I did more research about that. So I think even if the program specifically doesn't have information that's kind of confirming everything that they're saying, doing some more research into the broader either academic institution or the hospital itself where their program is housed.
Yeah, I would echo that. This whole process is very much like speed dating on crack. And so you really, that first date, you're going to get a feel for a program, but then reach out to the residents that, maybe are the social chairs or the social chiefs. Reach out to the coordinator, try to make some contacts. I think word of mouth is huge in this industry. So definitely don't be shy. Most of my residents would be willing to really, just have a good phone call with you. So
that's what I was going to say, Jeff. I agree. I think if you as an applicant, not necessarily the program director, but contact the program manager or the social media and see, is there a resident that would like to, I could talk to about it. I know that I welcome, and I have our chief residents or any of our residents, hey, you got this question, who wants to tackle it and represent our program? And then give it to you how it is. I don't want to lie about something I don't have. The last thing I want is for you to actually get to, our site and our program and not the expectation and reality ratio not be equal or better than what you expected. None of us want sad residents. We all want happy residents who are engaged and want to be part of it. Huh? I love it. Oh, they're laughing in the comments. Yeah. He's like, oh yeah, please get that old guy out of the.
No.
Any other questions? Any questions? Yeah.
I don't know if this was already said, but in terms of like letters of interest and stuff, what's like the happy point after the universal release date that's not waiting too long, but not too soon? If that makes sense.
I think that's tough. That's going to be very tough. It's going to be very tough for all of us. And I think I'm going to go with what Dr. Mark was actually discussing before. And what were they saying? I don't want to look because I'll get distracted. It's like too many lights areas for the chat.
Just toxicology.
See that? I missed that.
Oh, I said just a joking toxicology discussion.
Oh, I love it. Yes.
and waiting until after the universal release date, or when you feel that these programs have released that first round of invites, that's the most important thing. Getting an email before then is really difficult, because boy, are we working hard to give the time and attention to each of you that you deserve right now. If you have an update or something like a letter that is coming, wait for that. I know what a good reason to reach out if there's something that you can anchor that around or on. But otherwise, it's back to the sincerity. When it's a time that you've given the space, you're still very hopeful. Reach out with the reason that you're hopeful and why this would be such a good fit for you.
Ask. Yeah, I love it.
Hi guys, I have a question that might not be as, I guess, by the book. Can you guys each tell me something fun about your like geographic location? I'm from the West Coast, so even just being in Louisiana has been like new for me. And some of us in the program also are from the West Coast. So yeah, just something fun near your area that residents, faculty like to do.
So like one word unique or
just like one, I guess, like fun activity or something special about the geographic location that you're in.
All right.
It could overlap for some of you.
What sets you apart?
Yes.
Your particular site.
Yeah.
I like it. That was
less about applications, more just for fun.
I think so too. I like that. Who wants to go first?
I'll go first. Here at the University of Kentucky, we're in Lexington, which is about 30 to 45 minutes from the Red River Gorge. Though I personally am not a rock climber, a lot of our residents do come with that interest. So that is a little bit unique to our geographic area. We also are the home of bourbon. So if that is of an interest to anyone, that seems to be a popular reason people are interested as well.
Love it. Very cool. Bourbon and rock climbing. Just don't do it together. I like it.
I'll go. I am in Corpus Christi, but I'm originally from the Midwest. I never thought I'd be a birdie person, but Corpus Christi is like one of the bird watching capitals of the world. And we all get into it. We all go full nerd with bird watching down here. And shameless plug, there's a YouTube documentary called Listers that just came out. It is awesome. I never thought I'd be into a bird watching documentary, but it plugs Corpus a few times, and it's a cheap hobby that we all get into down here.
Wow, so we can get into like the Canon type telescope, and you can really nerd it out. I like it. Very cool. All right, anybody else?
At our University of Tennessee program, we're about a half hour outside of Nashville. Downtown Nashville is a lot of fun. You got the honky tonks, a lot of live music, every activity in the world, all the sports stuff. So always a lot going on.
I should be speaking up about East Carolina barbecue, but I see a lot of other very nice people that I don't want to offend in this professional setting.
Please offend them. There's nothing wrong.
Yeah, so instead I'll say, and a personal pastime is looking through the Trulia or Zillow in our area and feeling like I'm still in 2019 before COVID and all the housing prices happened. So the things you can get out here, it is beautiful.
I love it. So you're saying it's the best barbecue in the country?
I'm saying definitively, without consideration.
That's exactly what I want to hear. I love it because we can all fight on this. This is good stuff. Go for it, Jed.
Here in Dallas, especially since for the West Coast, this may sum up Dallas pretty well. You can surf here at 2 different bars. And that pretty much sums up Dallas. There is nothing that you can't do here. It'll blow you away. I'm not from here. I'm from a little town in South Louisiana, so it still mystifies me to no end. Places to surf, all kinds of things to do around here. Better barbecue than the Carolinas, for
I
sure.
love it. This is where we're gonna start.
I'm not so sure about Memphis. They're pretty good. I'll leave a spot for the ribs in Memphis, but we got some brisket here that will make you cry.
I like it.
And if we are talking about Dallas, I will also add that if you are visiting Dallas right now, one of the advantages is you can visit the Texas State Fair. It is one of the biggest fairs in America. It's kind of a Texas, I feel, rite of passage. If you live in Dallas, you probably grew up with your parents dragging you there. But if you ever wondered about fried foods, they fry about any food ever imaginable. pickles, avocados, Twinkies, you name it, it's there. So I will plug that for Dallas as well.
I love it. So cool. Anything fried is good. I like it.
With Houston, go ahead, Lauren.
Oh, thank you. I'll say Arkansas is the natural state. It is beautiful here. And so our residents are 15 minutes away from state parks where they can hike, where we hold our conference, our wilderness day, hold our resident retreats, all the way up to 2 hours away from the country's only national river, Buffalo National River, where you can kayak, you can hike, mountain bike, do all of the natural sports and all of the outdoor activities that you could hope for, even just on a weekend.
Very cool. You got the baths nearby too.
I'll go ahead. Hey, Jeff Bush, Charleston, South Carolina, MUSC. Charleston, South Carolina, it's a great tourist destination. People tend to love our Southern hospitality. In fact, the way you say Charleston here is Charleston. You have to kind of roll it out a little bit. We have great food all around. Lots of food, lots of culture, lots of history. The residents love the beaches here. You can go surfing, you can go kiteboarding, all that kind of stuff. It's a big tourist destination, but I think our biggest draw, two biggest draws, is we don't have a lot of birds, but we have mosquitoes the size of birds. So that counts. But it's a big dog-friendly town. Lots of things to do with your pet Fido. Just a great place to live all around. So that's all I got.
I guess I'll speak to New Orleans, especially as a New Yorker. It was kind of a big culture
Come on,
shock
Sarah,
down
give
here.
Jeff a hard time. Come on.
I just remember how friendly people were. I was not used to people talking to me in the grocery store. And in New York, you're just trying to get from A to B. Sal, you went to MIMO, right? So New Orleans, great music, amazing food. Obviously, we have Mardi Gras and all of the music festivals, which the entire city really shuts down to the sort of bare minimum emergency worker halt for 3 weeks every spring. We also have the swamp, and if you like to fish, you like to go kayaking, you can go out fishing and kayaking. There's unfortunately no close places for swimming in nature here. You got to go to.
I don't know if you want to go swimming in any of these dangerous custody lands. Yes, no, but
I like it. I think Jessica.
Yes, Dr. Wilson, did you have something to add?
Yeah, I was just gonna say, Houston it is a huge melting pot, and that you can also get as Texas as you want to be. You can, be in Houston and experience basically every culture in the world through its food, or their art. We have a big art scene. And then you can also get as Texas as you want with one of the biggest, rodeo and livestock shows in the country every spring. So we kind of get to run the whole gambit here.
Yeah, I'll go for Florida Atlantic University. We're in Palm Beach County, Florida, and so a lot of boating, great beaches, a lot of outdoor activities. When we're only like half the year, you feel like you're melting. And then the other thing that's nice is we're very close to also Broward and Miami without having all of the necessarily traffic or kind of craziness. You can easily get there for a weekend. Plus, there's a lot of really, really natural beauty out in the Everglades. You can go and bike around and go explore.
All right, San Antonio, the Alamo, obviously. No, just kidding. Don't ever go to the Alamo. You'll drive right past it.
It's much smaller. It's much smaller than you really think it is.
Yeah, it's tiny.
So you should definitely go check out the Alamo.
Yeah, but don't be surprised if you miss it, because if you blink, it's gone. You're like, wow, why? There's a reason why people have to remember the Alamo, is because it's not very memorable. San Antonio, I think, is the cultural hub of Texas. That's how I like to think about it. And really, I think about everything that we do outdoors all the time. And it usually ends with a cold beverage and probably a little bit of sweat. But I think that, that really kind of brings, San Antonio and Central Texas in. There's the Texas Hill Country. There's the second largest winemaking region outside of California. Anything that you want to do outdoors, you can 100% do, unless it involves snow and cold, because you will definitely not have any chance of doing that here. Because if there is even a chance of snow, the entire city shuts down for 2 weeks and doesn't know what to do.
I think that's unique for most of our programs in the South Central region. Anybody else? All right.
I think everyone else is going to so obviously save the best for last, Lubbock.
I love it.
I think one of the best features of Lubbock is that it's big enough and kind of isolated enough that if you're going to put something between Dallas and Albuquerque, it's probably going to be in Lubbock. And so we have a lot more amenities and things to do than you would expect in a city the size of Lubbock. But it is a quintessential college town. And so we have USA Today's #1 brew pub, #1 independent coffee shop, live music. And our fans, no disrespect to LSU, but our fans may even be crazier. And so basketball and football games are a lot of fun.
I don't know if that's a good thing, but I like it.
That's awesome.
Any more questions? I do have a couple questions on my, oh, perfect.
Yeah, we kind of alluded to this earlier, but what is the best way or the preferred way to stay in touch with a program after interview season?
Like after you've done your interviews before match?
Yes.
Best time to get in touch or what to do? I guess the question is really, what should I do as an applicant between an interview season and rank day?
Right.
Yes.
I would recommend getting in touch with one of the residents on one of the resident socials, making a connection, because it's really weird to text or email a program director just out of the blue multiple times, and I think students are hesitant to do that, whereas you don't have that hesitancy with a fellow resident colleague, and they will also ask questions or answer questions that you maybe wouldn't ask of a program director, and they tend to have a vested interest in recruiting for the program, and so they're a very good source of information. And I think many of them, if you find that connection, will want to help make sure, like Dr. Wilson said, that you're going to be happy when you're their colleague, that you're in the right place.
Yeah, I would echo that. There's a fine line between showing your interest and stalking.
I love it.
So I would prefer that you reach out to the residents that maybe you've talked to or met or through word of mouth, just to not only express your interest, but also answer any other questions that you may have in between that season of the interview and when you actually submit your list.
I know this is different for every program on here. For us, we're always happy to answer questions. I can direct you to where it needs to get to if you want to send it to the coordinator, if you want to send it to a resident. Don't feel you have to. Most of the time, kind of the additional conversations at the late part of the year for us are purely for you. They're not necessarily for us. And again, this will be very dependent on every program. We close out our rank list pretty soon after we finish interviews because we don't like to have our second looks affect the rank list. And so we close out rank lists well before second looks. So our rank list is done at that point. So it is purely for you. We want you to get the answers, get the information. We want you to know that information, but it's not for us necessarily.
I'll echo what Dr. Evans just said. I think every program does this differently, so it may not be universal, but we rank you the moment after you interview, and so all the communication afterwards is good if it helps you, but it doesn't usually change much, if at all, for us.
If there's something you couldn't communicate in an interview that has come up and is important, let them know. But yeah, any communication beyond that really is about you. And it needs to be sincere, and lack of sincerity shines, and sincerity shines. And we keep saying it because we all do this a lot, and it just keeps being true.
It's also important to recognize, sometimes it might not seem so right now, but emergency medicine is kind of a small world. So if you are unprofessional in a communication towards one spot, or if you send out 5 "I'm ranking you #1" emails, there's a good chance that we'll find out, because I may or may not have been, texting Dr. Gelber on this call. Many of us are colleagues, if not friends, and so just make sure that everything is professional and sincere.
I like that too, and I want to echo that not only in your intent, but in anything. I think the way you conduct yourself represents who not only you are, but the group of people you are. And something happens, I'm going to reach out, even if I'm not personally, best friends with Melissa or Jed or Sarah, whoever that is. I'm going to be like, what is going on with this applicant? This is a disaster or something. So I think that's also really important. So thank you for mentioning that.
And just to reiterate don't send out to 5 people you're #1. For whatever reason, one of the things that really sticks in our craw as program directors is when people say we're ranking you #1 and then they wind up somewhere else. Because we know if you should have come here or not. And there's a lot of people that are going to want to do fellowships. They're going to want to do academics maybe at that facility, and they're going to eventually come back around and
Get a job. Yeah.
you will stand out in our memory, but not in a good way, if you are not honest in that regard.
Even if we don't hold a grudge.
Well, it's holding a professional opinion.
Yeah.
I know this doesn't apply to everybody, but it does apply to a couple of us here. When and how is the best time to mention the programs about couples matching?
Ooh, that's a great one. Couples. So at what point do you share and do you email and say, hey, so personally, I have, since I've been a program director, at least locally, I actually reach out to, as a program director, I reach out to my surgery, all my colleagues at LSU, Tulane, at Ochsner, about people who I like that are couples, because I want to be able to also advocate for them and try to reach out if that's something where they're at that point. What do you guys think?
Yeah, I think the sooner the better on that, because we do the same here, and something that, not to tout Southwestern, but most of us big programs at university-based places, like, we can do great with couples. We've got somebody who's EM here, and then if you want to do surgery at Bumpsy or something at JPS, at Family Medicine, or any of the jillion programs at UT Southwestern, we can make that work. But it definitely takes us a bit of time. And it's something that if you're a super strong EM applicant and your partners may be a little bit lower, it's something we can get them an interview. Sometimes it goes the other way. Hey, Plastics has the perfect applicant and their husband would like to match into emergency medicine. That may kind of get them on an interview list. They wouldn't have had it otherwise. But it's something you want to get out there kind of early to the programs that you are legitimately really interested in. And I think the second part of that advice is realize it may be easier at some of the big giant kind of university-based settings, because we just have so many programs we can make that happen that are going to be maybe a little harder to pull off with that experience in a small town.
And I think that the other big thing would be, important updates about the progress of things. So, like on the interview day, 100% you should say, hey, just so you know, I'm couples matching with blank. They're going into this, we'll see it on the application. All the couples are flagged in residency CAS, but it also just kind of creates this to-do list for me that's like, oh, okay. And it's even like, it's good to know whether or not your significant other has gotten an interview at, especially the same institution that I'm at, because then I can either advocate or I can do the quick, like, hey, how did it go? And then kind of know pretty quickly like where this is going to fall. And then it kind of helps with like that communication down the line. So, even once that person, like your significant other, interviews at the same institution, a follow-up email that says, hey, just wanted to catch up. My wife loved the dermatology program there. And then it kind of like puts the ball back in our court to then kind of help advocate for the two of you to be at our institution.
Great. And I think we also recognize that a lot of our applicants that are couples matching are often casting an even wider net with number of interviews or number of applications than people who are not couples matching. And so if you find a program or if your partner finds a program that you are absolutely in love with or, really thinking about, it does help us to know that because it allows us to put a little bit more energy into that and start making coordinations.
Communicating, I think that through email and that same vulnerability and clarity and humility and like, hey, my partner really loved it, did very well, had her interview X or his interview X or Y date, and the same thing, what do you guys feel like if your significant other or your partner hasn't gotten any interviews in the area? How do you think the applicants should be? Should they kind of let that interview, release it for somebody else? What do you think? How do you guys feel like applicants should deal with that part?
So in response to that, one of the things I've noticed is that a lot of the more competitive specialties like optho, derm, ortho, they tend to batch their interviews a lot more, and they're on a little bit different timeline than we might be. And so if I have an applicant that's couples matching with derm, it seems like sometimes those programs don't multitask as well. And so when we send out and say, hey, we'd like to interview this person, their couple is matching with you, they may not get back to us or know yet whether or not they're going to interview. And so for that reason, we may hold off extending an interview. So the most powerful stimulus you can give us is saying, my couple is interviewing at your program. And so especially with the more competitive matches, that's a powerful incentive for us to interview you.
And we generally won't give interviews unless someone's partner is being interviewed, just because we are an hour and 20 from the next closest program. And what a hard situation to put someone in as a guarantee. And if someone's going to get that interview, then we would love to bring you in if you're a good applicant for us. So yeah, I think that's a great insight.
I think that's all
Cool.
really great. So
Yeah.
again, communication and letting them know one way or another, because I think that's very valuable and important. Do like a last
Perfect.
question or?
I have like a couple that
Okay, yeah.
I got sent in, if that's okay with y'all. Some people couldn't make it, but we are recording this session, so they'll definitely tune in later to see what y'all have to say. I guess one question is specific to slowies. I know that there are different components to slowies, but what part of the slowie do you look at first, or what's the most important thing about a slowie that you guys like and like sticks out to you?
I can read a slow, like I can read a patient's like quick reference tab in an Epic chart. Like it's a language.
Yeah.
We read hundreds of these and we know them well, and you can pick out the program name, and you're probably familiar with those writers, and you can pick out visually the categories. Does anything bump really far off in a professionalism, or holy cow, this person just ran fives across the board? And then you can pick out what place are they, put in the quartiles, and you can see immediately, well, they give everyone top 10. This is, oh my gosh, look at that. Like, look what they did. This is amazing. And then that narrative piece is real and it's important. And, slows are amazing, and we trust each other, and it's such a vital part of our interview process. It's the whole thing. It's a great little package.
I'll say if there's one question I had to look at on the slow and probably look at first, it's where that program's going to rank them on their list. I think that's the big equalizer. Everything else, there's a lot of variability in how people answer. Honestly, it's not even clear to me what that always means, the 1 through 5 scale on the other parts. But where they're going to rank you is kind of the ultimate truth.
Agreed.
Slows are kind of like when you're dating and you talk to a friend and the friend is like, you're going to love this guy. Y'all are going to be exactly compatible, versus your good friend that you trust saying, I don't know if this is really the kind of person that you're interested in. you know, we are colleagues, we do know each other, we know how each other think. And so getting a reference that, hey, I'd put this person in the top 10% of my rank list, I'm looking real hard at that person.
Yeah, the
Yeah, I
reality
think
is, go ahead.
yeah, after like ranking, I'd say the guidance question. Those are like the two that like boil down, I think, a lot of it, because the guidance question, the person could, you know, rank out well, but if they seem to need more guidance for whatever reason, that's usually explained more in the narrative. That might, you know, either give some people that, oh, this is a great fit, or this is a person who maybe belongs at a, you know, a program that can have, you know, more attention, a smaller program, versus a program that's larger and may not have the ability to have as much guidance for that person.
I may be in the minority here, but to me, one of the most interesting things on the slow is where you rotated. Because, you know, signals are valuable because you only have 5 of them. Rotations are even more valuable because you have the same number of weeks as everyone else. And so if I see someone who was considering living and training in a city that I think is similar, or a program that's similar to ours, then I'm very interested in that slow. Whereas if I see someone who, you know, like we're in Lubbock, and if your 3 slows were from New York City, I'm thinking we're probably not what you're looking for. And so I think to me, where you rotate can also open up different or similar areas in certain
Yeah.
places.
The other side
Yeah,
of
I
that
think I
is if
100% agree with Dr. Morris. Oh, sorry, Josh. I was
no,
saying
go
I
ahead.
completely agree with Dr. Morris there. The thing that sticks out to me is where did you rotate? And was it another county hospital program? That letter is worth to me 15 times than a top 10% from some smaller community-based place that in a state that is in no way, shape, or form connected to Texas. So that I think, like Dr. Morris is saying, if it's similar in either city scope or in kind of the patient population, the hospital setup, that carries a lot of weight too.
That geography one, and it works against you if you went to 3 places in Florida, and I am not in Florida. But if you really want to be in Florida, what a great way to show that you want to be in Florida. It's not a double-edged sword. It is an indication, for better or for worse.
It's what's driving you.
Okay, thank you guys. Just like 2 more questions or something like that. That's okay. Another student had asked, how can students with maybe years off or failed boards or any other academic challenges still interview and match? How has your program specifically handled these students in the past?
Don't run from it. Lean into whatever is the big thing that is the elephant in the room in your application, and know how to talk about it. This is your time to reflect on what happened between whatever result was and now, and how you have addressed it, how you've gotten better, how, you know, whatever has happened. You know, there are so many data elements that we get in your application. We are going to still see the big red flag. Like you will not be able to talk your way around something or hide yourself from something. And so learn how to start taking that, whatever it is, whether it's a failure or redoing your first year of medical school or remediating a course, what happened, how you learned from it, and then what you've done since then to become better. Don't like write a personal statement that involves none of those things. That's just like, I love emergency medicine. It's really fast paced. That doesn't help you at all.
Yeah. It's not so much the fall, it's what caused you to fall, and did you get back up, and how are you going to prevent that fall again? You can't hide it. In fact, I get very frustrated when people do try to hide it, and you got to really hunt for, well, okay, why did this person spend 7 years in medical school? And you got to really look for it. Just address it right off the bat.
Yeah, I mean, our day job is to assume the worst case scenario. So if there's missing information, you don't want to think about what we're going to impute as the cause. It's much better to just be transparent and tell us what it is and let us figure out if we can deal with that.
That's funny, but it is so true.
And Josh,
I
put
do it
something-
in the written application because it may be the difference between you getting an interview or not. And you know, if you're just a bad test taker or you have low or mediocre scores, if you're accounting for that with other experiences on your CV or a lot of research experience, and then being able to write about it, and then if you get the interview, being able to speak about it.
Yeah.
And then Josh had put something in the comments about kind of insight. And I think that's always big too, is when you're explaining to me something that happened, if I hear, and so did this to me, and then they weren't a good educator, and then this, it worries me for how you're going to come in and respond if some kind of adversity hits you whenever you are in my program.
And inviting us to ask more is wonderful too. Saying this is what happened in a written way, and I would love the opportunity to share more about this if you
Give me the opportunity. I agree.
I think a lot of us are looking for candidates that have a growth mindset. You have to have a growth mindset to get through residency, and avoidance of challenges and how you overcame them and what you learned from them often indicates, a lack of that growth mindset. But being able to show insight and show reflection and growth out of a challenge is, I think, something that we're all looking for in candidates.
Yeah, I can speak personally that if you have insight, you're transparent, you've demonstrated growth, you don't run from this, then you come rotate at our program and crush your audition, you're going to be a very competitive applicant, despite a board failure or a gap year in med school.
Yeah.
And a lot of slow writers will acknowledge that for the benefit of each other in this space. Say, even though this person has a history of like that step one failure, we watched them lean in during this rotation, and their success on the shelf at the end of the speaks to this. Like we will be your advocates if you can show that you have that insight and that growth and in that capacity.
Love it. That's really.
And just to piggyback on what everyone else says, I think in terms of also in personal statement, there's also an optional reflective statement in the application. That's a great place to highlight that. And as you're preparing for interviews, sometimes when I'm talking with students that have, something in their application they're worried about is, there are common questions. Maybe your medical school, they have, mock interviews or, there are, tell me about yourself, right? Like there's common questions that are going to get asked in your interviews, kind of framing how you're going to integrate that in and maybe talk, and have kind of how you're going to address that ahead of time and kind of give yourself that space to maybe bring that up in the interview and address it head on. I think that also is kind of sometimes a good strategy for people because it gives you time to kind of think about it ahead of time. So rather than the interview maybe asking it in a way that catches you off guard, you are ready to address it when the question comes at you.
I think as well, all of the people here believe that we can teach you emergency medicine. So if you've got some sort of academic issues, I think program directors are a lot more willing to forgive those. If I don't have to teach you, like how clocks work and how to show up on time and work hard when you get there, so be transparent and say, I had difficulties with testing or I did whatever, but show that you've worked hard and you've overcome that. And I don't think anyone here is going to be too scared about a board failure or a repetition of a year.
I'd say professionalism red flags are, I think, always bigger red flags than academic red flags.
And if you can bring a solution forward to a program, I mean, that's in every sense, every day as a resident as well, but say, yeah, I have a history of this testing struggle, and then here is my strategy that I have laid out. Or, heaven forbid, I have this history with a DWI because it's not okay, but these things happen. And I want to be enrolled in this system of this monitoring program, bringing these things forward as your solution, your dedication, your commitment to growth and success is another, if it's sincere, excellent way to.
So transparency, ownership, and that you're willing to learn. Like somebody said, we can definitely remediate medical knowledge. That professionals and non-cognitive skills, those are the ones that are really difficult because I don't know how to remediate those.
I've got to head out and take care of some children downstairs, but it was very nice speaking with all of you, and good luck this year, next year, whatever year we get to meet you.
Awesome.
Thank you, Dr. Pathman. I think our last question, unless anyone in the crowd has a question that someone has sent in, more of a happy note. What is something unique about your residency program that your applicants should know about?
Outside of the birding hobbies that we have.
That's a good one.
Relative to the program itself and the education, we're unique in that we're unopposed here. We do not have any other training programs within our hospital inpatient setting. There's a family medicine program in the outpatient setting, but there's no general surgery, orthopedics, IM. So anything that comes through the door, whether it needs a chest tube, thoracotomy, reduction, sedation, etc., all that resuscitation, either we're going to do it or nobody is. So we're a little unique in that way.
Yeah, here at University of Tennessee in Murfreesboro, we're also an unopposed residency program, and I'll echo I think it's great for education. I would say one of the things very unique about us is we're one of the relatively few programs in the country that all the faculty are part of an independent democratic group, and gives a very different perspective on the non-clinical and business aspects of emergency medicine.
I would say here in Charleston, MUSC, we're the end all be all. In other words, all around South Carolina, it all ends up with us. We transfer nothing out. And so you want to see critical care, you will definitely be seeing some critical care here. Stroke center, cardiovascular center, most of the transplants are done here. So it's the end of the line for us. And so you get to experience that, the complex patients every day.
At UAMS, we have something called shared ownership philosophy. And so that's a big part of our program. We want our residents to be involved in our program. We want them to be owners of the program. We meet once monthly with the residents who bring forward their ideas about the program and their solutions. And we've had some really great changes made to our program over the years that have come out of our shared ownership philosophy. And I think it really kind of sets our program apart, and we enjoy that component of it.
Yeah, I think for us in San Antonio, it's really about investing in you and like understanding that wellness is not just like go yoga. Wellness is really about like taking the like treat yourself components of like feeling good and being happy, but also being able to look in the mirror and see what you can do to make yourself better, and creating an environment where you feel like it's okay for you to be vulnerable and to give yourself the opportunity to get better, knowing that you're in an environment where people are really invested.
Here at UK, a little bit different than perhaps some programs. We don't do graduated responsibility, so all residents are allowed and expected to see patients of all types from day one. And we also don't do a pod system, which in my opinion is better for education. So those are some of the kind of unique qualities of our residency.
At Florida Atlantic University, kind of our unique is that we have a longitudinal curriculum. So we do integrated EM, PEDS, quality, EMS, admin, and everything basically throughout the year. That way there's not really seasonality to a lot of the experiences. And that's, again, I think that with a small, 6 per year residency is pretty unique.
I think in Lubbock, one of the most interesting things about our training environment is that you get to see a lot of different flavors of medicine. We're the medical school, Texas Tech, so we've got all the academic flavors. We're the county hospital for Lubbock County, but we're also the hospital of choice for the community. As EM, we're independent contractors. We're not employees of the med school, so you get to see a little bit more how community ER would work and how community physicians learn about things like RVUs and throughput and other factors like that may not be as much of an emphasis at more traditional academic or county facilities. So you kind of get to see a little bit the best of all three worlds.
And here at UT Southwestern in Dallas, I guess not to rip off on Lubbock, but I think we're pretty similar in that same front that you got. We spend about 70% of our time at Parkland, which is the busiest #1 by volume ED in the country. Super busy. You'll see everything watch the door. We've also got Clements University, the Quaternary Care Center. So the tough part there is, do I consult the left toe transplant team or the right toe transplant team? And then we also have Children's Medical Center in Dallas, so huge ped center there. And our residents get to spend a good number of months at Harris Methodist in Fort Worth and Presby Dallas and then Hunt Regional. So we get you kind of exposed to some of the community aspects as well. Not as much as the community-based programs, obviously, because we're mostly county, but you get to see a little bit of that flavor. What's it like to be an independent group, or what's it like to work with one of the big corporate medicine groups? How's medicine look like out there? So pretty proud that we get you exposed to everything while keeping our core county.
Dr. Swallow.
Everybody's, I think I want to, say thank you.
And
That's great.
what about Ochsner?
Oh, Ochsner. Well, listen, Ochsner to me is a great facility. Yeah, we're a 3-year institution, and we are trying to find the individuality and long-term career pursuits. So becoming a great clinician, resuscitationist, proceduralist, but also pursuit of, long-term career development and passions and goals. So I think it's important. Longitudinal curriculums we have really important to, as a second and third year, we increase significant community experiences. And even at main campus here at our main facility, we really want to make sure that you're being educated as if you're working in a community ED. Just because we have X, Y, Z does not say that is your patient. You should ownership of that patient, resuscitation, stabilization of those things, I think are really, really important at our facility. And I'm sure many of all you guys as well. So I think that's something we all share. Go ahead. Sorry, somebody else. Or not. All right.
Are there any more last running questions before we close out our event? Nope. All righty. Yes. Thank you all so much. Thank you so much to the program directors for tuning in on your Saturday. You probably don't have too much time off, so
They're probably going through applications.
Yeah.
And still like maybe trying to figure out where we're at.
Yes, definitely. We have all of your institution names on the AAEM event site. So if they want to contact, your department, definitely. But if anyone wants to leave their contact information in the chat box for our students to ask you guys more questions, please feel free to do so. But thank you guys so much. And we will be in touch.
Thank you so much, you guys, for coming in. I appreciate it. All right.
And this recording this Zoom will be recorded, so we can, save the
You
chat.
should have said that in the beginning. We should have said this.
I wanted people to come.
Too late now.
Yes. Thank you guys. Appreciate it.